all, all the PGs, all the faculty who are going to participate in the South Zone conference. It's indeed a great honor for us to conduct this conference, and I congratulate Ramesh for taking all the pains to organize all the papers received and then organize them into batches so that all of your presentations are looked into, and then I wish all the participants a huge success in the conference. Over to Ramesh.
Thank you. Thank you so much, sir. Once again, I welcome all the delegates, PG delegates, for this conference, virtual conference. Regarding guidelines, already we have posted in the group to the case report presentations. In this case report, we have the only 5 minutes to 5 minutes for the presenter. The presenter has to finish by 5 minutes only. If they finish within the 5 minutes, then only judges can ask some questions to get good marks. So there are marks for different aspects, their presentation to quality, content, and relevance. So finally, adhere to the time and start your presentations. Meanwhile, our organizers may join in between. So we'll go ahead with the permission from the judges. I welcome Dr. Rajendran Dinesh Kumar sir from the Rajarajeshwara Medical College, Bangalore, and Dr. Anish Krishnan sir, the Secretary of Kerala. Please welcome to this session, sir. With your permission, we'll move to the next candidate, sir.
Okay, sir. Okay, sir.
Thank you, sir. Ramji, you can go ahead.
Hello, yes, sir. Yes, sir. First candidate is Dandaboya Karthik. First presenter, be ready. The presentation.
Sir, the time is 5 plus 2, sir. 5 plus 1.
No, sir. The
5
time
minutes.
is, sir, the time is only 5 minutes only, sir. They present within 5 minutes only. They can take the question, sir. There is an online timer will come, sir. Sir,
Sure.
Ramji, you take care of the timing.
Yes, sir. Yes, sir.
Before you mute one of your devices. That is take.
We are 3 assistants, 4 assistants.
You please mute other devices, Ramji.
Yes, sir.
There is an echo coming from your phone.
Okay. Okay. Phone. Other devices we have on.
Yeah. Before 1 minute, just to give a warning signal to the presenter. There is a 1 minute left. After that, they can finish up within the 5 minutes. Okay.
Okay.
So, okay. Let's move. Yeah, Karthik, you unmute yourself and start your presentation, and you have to show your face also. Okay.
Yes, sir.
Start your video.
Sir, I started, sir.
Yeah, you start. Timer is starting. Okay.
Yes, sir. Can I start, sir?
Okay.
Can I start, sir?
Yeah, you go ahead. Don't wait.
Yes, sir.
Yes, Karthik. Dr. Karthik, you can start.
Good afternoon, respected sir. Today I am going to present a case report on sinonasal adenocarcinoma. Myself, Dr. Dandaboya Karthik. A 42-year-old male came to ENT OPD with chief complaints of left-sided nasal obstruction since 4 years. Patient was apparently asymptomatic 4 years back and then developed left-sided nasal obstruction, which was insidious in onset and gradually progressive in nature. There is history of left-sided nasal discharge, history of bleeding through left nasal cavity, history of loss of sense of smell on left side. There are no other ENT complaints. Personal history was normal. Past history was not significant. General examination was normal. Coming to local examination, nose, on anterior rhinoscopy, a whitish, pale, smooth, glistening mass seen in left nasal cavity, obscuring the view of behind structures. Probe test was done and mass was non-tender and bleeding on touch. On posterior rhinoscopy, bilateral choana were visible. Examination of paranasal sinuses showed tenderness over left maxillary and left ethmoidal region. Functional test of nose were done and there is decreased movements of cotton wool test, decreased fogging on cold spatula test, and there is no improvement of breathing on Cotill's test on left nose compared to right. Examination of ear and throat were absolutely normal. Examination of cranial nerves are normal. Systemic examination, normal findings. Coming to the provisional diagnosis, query left infected sinonasal polyp. Investigations were done, all routine blood investigations were done, and every report was normal. Diagnostic nasal endoscopy was done. It showed whitish, pale, smooth, glistening, polypoidal type of growth in left nasal cavity. Then CTPNS was done, and the report revealed as possibility of fungal sinusitis. Management, left functional endoscopic sinus surgery was done, and the sample was sent for histopathological examination. And the HP report came as sinonasal adenocarcinoma. So coming to the final diagnosis, it is a case of left sinonasal adenocarcinoma. Coming to the discussion, the sinonasal carcinomas are rare and heterogeneous group of malignancies that originate in nasal cavity and paranasal sinuses. The most common are sinonasal squamous cell carcinoma, adenocystic carcinoma, and adenocarcinoma. There is persistent exposure to wood and leather dust, textiles, and organic solvents over a period of time is a strong risk factor. Other risk factors include smoking and HPV exposure. The sinonasal carcinoma is more commonly seen in men. The average age of presentation is 50 to 70 years. Coming to the sites comprises of nasal cavity, maxillary sinus, ethmoid sinus, and sometimes sphenoid sinus. Coming to sinonasal adenocarcinoma classification, it is of two types, salivary type and non-salivary type. Coming to non-salivary type, it is further divided into intestinal type and non-intestinal type. And non-intestinal type is further divided into high grade and low grade. Coming to the clinical features, the tumor grows locally and extend into adjacent structures. Clinical symptoms are mostly non-specific and they include nasal obstruction, persistent rhinorrhea, epistaxis, and facial pain. There will be proptosis, diplopia, and other neurological symptoms with the advanced disease. Lymph node metastasis is more commonly seen in sinonasal squamous cell carcinoma in about 10 to 20% of the patients, and lymphatic metastasis is rare in intestinal type of adenocarcinoma. Coming to diagnosis, routine investigations like rigid nasal endoscopy, non-invasive imaging like CT and MRI should be performed. MRI is the standard imaging modality for post-operative surveillance. Role of PET-CT is important in staging of squamous cell carcinoma, allowing the identification of regional and distant metastasis and biopsy. Treatment. Surgical resection has been the mainstay of sinonasal cancer management. Resection results in excellent control rates. For small localized tumors, complete removal is possible with less invasive techniques. Radiotherapy is given post-operatively in most cases, even if the margins are negative. Adjuvant chemotherapy is considered in case of inadequate resection margins. Concurrent chemoradiation can be used for those with comorbidities who are contraindicated for surgery. Radical neck dissection or elective radiation therapy of the whole neck can be done for the patient with positive lymph node status. And in case of intestinal type of adenocarcinoma, which are typically less response to chemotherapy, use of radiotherapy is preferred. These are the references. Thank you, sir.
Sir,
Okay,
judges, any questions can be asked, sir.
Yeah.
One or
Dr.
one.
Karthik, I'm Dr.
Yes, sir.
Ganesh here. What was your
Yes, sir.
histological
Good
subtype
afternoon,
in
sir.
this case? Good afternoon. What was
Excuse
your
me, sir.
histological subtype? What was your histological subtype in this case?
It is well differentiated type, sir. Comes under intestinal type of sinonasal adenocarcinoma, sir. In non-salivary type.
So, what was the prognosis for your patient? Follow up.
5 years survival rate is there, sir, after taking radiotherapy.
Sir, time up, sir. Can we start?
Okay.
Karthik,
Yes, sir.
Next candidate,
it would have
Dr.
been like hello.
Yes, sir.
Can it have been like a biopsy followed by a complete removal of the tumor either through a maxillectomy with free margins like that?
Yes, sir. In advanced stages, if it is bone erosion is seen, then we can do this lateral rhinotomy, partial medial maxillectomy, sir, combined with ethmoidectomy.
Okay, thank you.
Next candidate we can have.
Next candidate, M. Roja. Be ready. Next candidate, M. Roja, please join.
Yes, sir. Hello.
Yes, you can start, Roja.
Yes, sir. Good afternoon, sir. Today my topic is neurofibromatosis of neck. In ENT OPD, we come across with the primary parapharyngeal space masses, where the symptoms are usually rare and not significant. But if not diagnosed early, continued expansion may lead to potential life-threatening complications. Here is a case of 22 years old female who is a resident of Hyderabad, complains of swelling over the light-rated aspect of the neck since 5 years, which is insidious in onset, initially of pea size, gradually progressive and attained to present size, not associated with pain, no aggravating and relieving factors, complaining of similar swelling over the right arm since 3 months. No history of difficulty in swallowing, change in voice, cough, shortness of breath, no history of fever, loss of weight, evening rise of temperature, loss of appetite, no history of syncopal attacks, anxiety spells, no history of other complaints. In the family history, her father had a similar complaint of swelling over the arm, and the past and personal histories and menstrual histories are insignificant. On general examination, there are multiple coffee-colored hypopigmented spots of size greater than 15 are present over the body, and systemic examination has no abnormality detected. On local examination, on inspection, a smooth single overt swelling of size 16 to 4 centimeters over the right lateral aspect of the neck, anterior to the upper part of the sternocleidomastoid muscle, extending from the angle of mandible to 4 centimeters above the right sternoclavicular joint, medially 3 centimeters away from midline, and the margins are not clearly demarcated. Multiple hypopigmented patches are present on the skin over the swelling. No sinus or tracts, no pulsations noted, no impulse on coughing, no movement with deglutition. On palpation, all inspectory findings are confirmed, and it is firm in consistency. It moves along the horizontal plane. And rest of the neck examination and ENT examination are normal. On investigation, routine blood investigations are normal. On ultrasound, there is a hypoechoic lesion noted and no evidence of flow void signals. And FNAC, it confirmed as a suggestive of neurological origin. VLS, video laryngoscopy is normal. On CT, hypodense lesion is noted within the intravascular plane, suggestive of neural origin. In MRI with contrast, there is a lesion noted displacing the sternocleidomastoid muscle and the carotid artery, and there is a widening of the jugular foramen is seen. Treatment in the management, the patient is counseled about the operative procedure, possible recurrence, and cranial nerve palsy. The patient has undergone with tumor excision with transcervical approach, where the incision is given within transcervically, and the subplatysmal flaps are elevated, and the sternocleidomastoid muscles are retracted, and the tumor is noted within the carotid sheath along the length of the vagus nerve. Here, the tumor is seen extending to the upper jugular foramen. This is the picture of the post-surgery, where the tumor is seen in the upper end, and along the length of the vagus nerve, the small lesions are noted. This is the bed of the tumor. And on post-operative, the patient is kept on mechanical ventilator and noradrenaline for 1 day and later weaned off. The patient had hoarseness of voice. On video laryngoscopy, the patient presented with a right vocal cord palsy, and the patient 1 month, and the patient is counseled about the normalization of the voice later. And histopathological examination, it shows a benign spindle cell neoplasm, morphologically favoring neural in origin. And discussion, we have neurofibroma, which is a benign tumor derived from the peripheral nerve sheath. It is of 2 types, neurofibromatosis 1 and 2, where neurofibromatosis 1 is an autosomal dominant disorder caused by the decrease of production of the protein neurofibrin, which is a putative tumor suppression gene. We have a classification for the diagnosis of the neurofibromatosis type 1, where the patient with 2 or more of the following features, like 6 or more cafe-OLED macules, or 2 or more fibroma of any type or 1 plexiform neurofibroma, freckling in the axillary or inguinal regions, optic glioma, leaf nodules, or distinctive osseous lesions such as sphenoid dysplasia, family history of first degree relative with neurofibroma. In the present case, the patient reported with the positive family history, multiple neurofibromas, and cafe-OLED spots suggestive of neurofibromatosis. These are my references.
Time up.
Thank you.
Next
Yeah,
candidate, R. Saujanya. Sorry, sir.
No problem. Very well presented. I think you have covered every point. We'll go to the next candidate. Sir, anyone, any
Yes,
questions?
sir. R. Saujan.
No, sir. Next candidate we can move.
Next is R. Saujanya Nayak.
Yes, sir.
सर डिलीट इसलिए यार सर चेंजेस क्यों नहीं यार
करना क्या
Yes, we can hear.
ये
Can you
पॉजिटिव
put the
फाइंडिंग्स
presentation?
खाली रखना है रखना
Good
है
afternoon, sir.
Yeah.
Good afternoon, sir.
Yeah, go on. So, Janya
This is Dr. R. Saujanya Nayak, sir. I'm going to present a case report on cerebellar point and angle tumor management, sir. It's a case report of a 10-year-old boy complains of left ear discharge
ये नहीं
since
मतलब
5
इसको एडिट
years.
क्यों नहीं कर सक
Left
रहे
ear,
प्रोटेक्टेड व्यू क्यों नहीं
ear mass since 5
enable
years
delete ये
and
तो
hard of hearing since 1 year. There is no history of giddiness or headache. Past history, preoperatively we have taken a biopsy and a GA from left ear which showed a benign polypoidal lesion with chronic inflammation. On local examination, right ear was normal, but in left external auditory canal, there was a pinkish mass seen, which was mucoid discharge. On probe test, it was not tender and not bleed on touch. Probe cannot be passed around the mass. And tuning for test, right ear was normal, whereas in Rennes was negative and left. Weber's was lateralized to right. There was absolute bone conduction. There was decrease when compared to the examiner. Audiological examination of pure audiometry, the left ear showed profound mixed hearing loss. On CT bone, there was a left ear external auditory canal. There was a completely opacified soft tissue mass was present. The bony labyrinth was the vestibule was underdeveloped, and even the soft tissue was seen in the internal auditory meatus, which was widened. And then an MRI brain, there was a mass which was around 2 into 8 into 1.2 into 1.3 centimeters large, which was present in the CP angle, and it was protruding into the uh, external auditory canal, middle ear, and as well as in the internal auditory canal. And the provisional diagnosis, what we thought it was cholesteatoma. On surgical management, we approach was like translabyrinthine approach, because since there was a underlevel labyrinth and the patient was completely compromised on hearing, so we thought it is best to go for translabyrinthine approach. And first, the overview, we had a post-auricular incision given 4 centimeters behind the post-auricular groove. Then the complete mastectomy was done, labyrinthectomy done, and then we have closed it. And while doing the cortical mastectomy, we saw a mass was present, a blackish mass was present in the middle ear cavity. Then we have identified the facial nerve, and we have translocated the facial nerve from first genu to styloid mastoid foramen. And the sigmoid plate was removed, and the sinus was exposed. You could see the sinus, the sigmoid sinus. And then after labyrinthectomy, petrosectomy done, we have entered into the internal auditory canal and CPI and cerebropointal angle reached and exposed. When we exposed, there was a mass present which was abutting the 7th and 5th to 7th nerve complex, 6th nerve, as well as anterior and inferior cerebellar artery. After removing the mass in piecemeal, we could see the sixth cranial nerve as well as anterior and inferior cerebellar artery was preserved. You can see, so the thick one is the 6th nerve, and the behind one is the ICA. After tumor removal in toto, we could identify and preserve the 8th nerve, which have marked with blue. There was a mild CSF leak was present, for which it was sealed with Surgicel and fascia lata. Cavity obliterated and fascia lata, temporalis muscle fat, and was kept. Blindside closure was done for external auditory canal. On post-operative, the patient developed grade 2 facial palsy and mild greater rectus paralysis. Consent was taken for the patient while posting this picture. Post-operatively, the HPA, we have sent in 4 samples, which we have taken from left TAC, mastoid antrum, left medial ear cavity, and left CP angle, which all the 4 have suggested a mature teratoma. And differential diagnosis: congenital cholesteatoma, granuloma, meningioma, lipoma, arachnoid cyst, vestibular schwannoma. And surgical approach, what we did was translabyrinthine approach. Its indications are extended CPA, non-serviceable hearing, adequate contralateral hearing, and contradiction is a serviceable hearing. Advantages: we can go for a wide cerebral pointal angle exposure. There's the lowest recurrence rate, and we can express the tumor in cochlea as well as labyrinth. But the limitation is there is a hearing eliminated, CSF leak, and complications must be there. Could be there with this translabyrinthine approach. And in conclusion, the biopsy consists of mature teratoma. Intracranial mature cystic teratoma are benign neoplasm that can occur at any midline. Mature cystic teratomas at cerebral pointal angle are very rare. They are unique germ cell tumors which are curable by safe total surgical resection and good prognosis. And the patient is advised for 6 months follow-up, sir. Thank you,
Sir,
sir.
any questions, sir?
Yeah, what is
Good
the
presentation.
yeah, very good presentation and good images as well. Did
Thank
you
you,
use
sir.
a nerve monitor during the procedure to
No,
assess
sir.
okay,
No,
fine.
sir.
And regarding your condition, what is the prevalence of this condition?
So extremely rare. So it's around 1% to 1 to 3% of the prevalence is mature keratoma and CP angle.
All right. Very good images. We can have the next speaker. Thank you.
Thank you,
Next
sir.
candidate, Anshita Jam. Dr. Anshita. Yes.
Good afternoon, sir.
Yes,
Shall I
Anshita,
start,
you
sir?
can. Yes, you can start.
Okay, I'm presenting a case of laryngeal rhabdomyosarcoma in adolescent male, which is a rare case report. Rhabdomyosarcoma is a rare and aggressive cancerous tumor that arises from the embryonic mesenchymal cells with skeletal muscle differentiation, and it is extremely rare that it occurs in larynx. Here we are presenting an common occurrence involving a 17-year-old adolescent boy who experienced progressive hoarseness and dyspnea. A 17-year-old male patient, resident of Bihar, student of 9th standard, presented in ENT OP with complaints of change of voice since 1 month, difficulty in breathing since 20 days. The change of voice was hoarse in nature, insidious in onset, constant throughout the day, and no aggravating and relieving factors. Difficulty in breathing was since 20 days, insidious in onset, initially mild with noisy breathing, gradually progressive, present constantly throughout the day, increased since 1 day. So my screen has gone, sir. Someone else has.
Can someone help? The screen sharing has been disabled.
Someone else started, sir.
Yeah, you can
Of
see
the
that.
timer, once the screen is on, I'll.
Okay, sir.
Yeah. Now you can start, Anshita. I've stopped the timer. From here,
Okay,
it will be continuing. Okay. Yeah.
Okay, sir. There was difficulty in breathing since 20 days, insidious in onset, initially mild with noisy breathing, gradually progressive, present constantly throughout the day, increased since 1 day with no aggravating and relieving factors. History of voice fatigue present, no history of pain in throat, chest pain, cough, pain in swallowing, fever, weight loss, loss of appetite. There is no history of vocal abuse, trauma to neck surgeries, and radiotherapy. Past history is insignificant. Personal history and family history are also not contributory. On general examination, patient was conscious, coherent, cooperative, moderately built and nourished. Patient was in biphasic stridor at the time of presentation. There was no use of accessory muscles of respiration, no cyanosis, chest retraction. Vitals were normal except that SpO2 was 95% on room air. Systemic examination was also found to be normal, except that there was biphasic stridor. Oral cavity and oropharyngeal examination was normal. Neck examination was also normal. Laryngeal framework was normal. There were no lymph nodes palpable. Nose and ear examination was normal. Investigations on indirect laryngoscopy, a pinkish sessile mass seen attached to the undersurface of the left vocal cord, crossing midline, obstructing glottic lumen. Right vocal cord is free and bilateral vocal cords were mobile. On video laryngoscopy, left vocal fold, a pinkish pale smooth mass seen arising from the undersurface of the left vocal cord, crossing midline, involving anterior commissure, obstructing the lumen completely, but not involving the right vocal cord. Both vocal cords are freely mobile. A grayish glistening mass visualized in subglottis. The glottic chain was inadequate. Bilateral piriform fossa is normal. Rest everything was normal. So, in USG, there was a well-defined heterogeneously hyperechoic mass seen arising from the left vocal cord, abutting right vocal cord, causing laryngeal lumen narrowing. On CT scan, We can see here sagittal and coronal section of the CT neck showing 2.2 into 1.4 into 2.8 centimeter hypoechoic soft tissue lesion, the extent of which is from the mid-level of the C4 cervical vertebrae to mid-level of the C6 cervical vertebrae, approximately 12 mm above the tracheostomy tube. So, there is no erosion of the laryngeal cartilages, no involvement of the paraglottic space, no involvement of the parapharyngeal spaces. Under local anesthesia, first we did mid-tracheostomy to secure the airway. Under general anesthesia and suspension laryngoscopy in Boyce-Jackson position, it was noted that mass was arising from undersurface of the left vocal cord. It was involving anterior commissure and extending into the subglottis, involving mucosa of anterior and left lateral wall of subglottis. We took biopsy for HPE and mass was completely resected using coagulation. Post-operative period was uneventful and patient was discharged on post-op day 5 with tracheostomy tube in situ and asked to follow up in OP with HPE report. In HPE report, it showed to be a tumor of the mesenchymal origin and it was confirmed as a case of rhabdomyosarcoma using immunohistochemistry, which was positive for desmin. Then we referred the patient to medical oncologist for further treatment, where he was started on chemotherapy of VEC regimen, that is vincristine, actinomycin D and cyclophosphamide. Patient has completed total 9 cycles of the VEC regimen and he is being followed up in OP with regular clinical examination, which is normal till day. Discussion. This case represents rhabdomyosarcoma in adolescent male, and the initial presentation of hoarseness, dyspnea, dysphagia is misleading because it is overlapping with symptoms of other inflammatory and benign laryngeal conditions. So, thinking laryngeal rhabdomyosarcoma is a very rare entity. It requires high level on the part of the clinician to suspect this condition. And laryngeal sarcoma present less than 1% of the total laryngeal neoplasm, among which laryngeal rhabdomyosarcoma is extremely rare. Till September 2023, only 22 cases of laryngeal rhabdomyosarcoma have been reported, and there are various approaches for the management, like surgery followed by chemotherapy, surgery followed by radiotherapy. Here we have chosen the organ-preserving surgical approach.
Time up, Anshita, Dr. Anshita.
Thank you, sir.
It's a very nice case, and I think the challenges are also equally there to approach.
Yes,
Transoral. Do you
Yes, sir.
have laser facility in your institution?
No, sir, it's a government institute, so laser is not there. We used coablation, sir.
You have used the coablation or coablation?
Yes, sir. We have used transoral coablation, sir. Resection with coablation.
Okay. So how did you decide on the margins?
So margins actually, the tumor was involving the mucosa of the larynx. So the margins were positive, sir, after surgery in HP. So we could not get a margin-free resection, sir.
Okay.
Yes,
All
sir.
right. Thank you.
Thank you, sir.
Sir, shall I call the next candidate, sir?
Okay,
Yes,
sir.
please.
Okay.
Dr. Salma Fatima.
Yes, sir. Can I start?
Can I start? Yes, Dr. Salma Fatima, you can start.
Good afternoon, all the judges, senior faculty, and my dear friends. Today, I am presenting a management strategy in a case of frontal lobe abscess due to chronic rhinosinusitis. Rhinosinusitis is a very common disease worldwide, and though use of antibiotics has made intracomplications rare, but it can be a cause of serious concern. Complications arise more commonly via indirect hematogenous spread than through direct spread via bone defect. Sinus is usually the primary source of these complications, and a usual course of management involves a multidisciplinary approach with neurosurgical drainage of intracranial extension. A 22-year-old female patient presented to the ENT OP with chief complaints of right-sided nasal obstruction since 2 years and headache since 2 years. The right-sided nasal obstruction was insidious in onset, gradually progressive, initially intermittent and relieving on use of topical decongestants, and later aggravated since 2 months. History of watery nasal discharge was present and reduced perception of smell was present. Headache was since 2 years. It was insidious in onset, bilaterally frontal region, episodic throbbing type, and relieved on use of medications. No history of ear or oral cavity complaints and no history of diplopia or blurring of vision. She was a known case of dust allergy since 3 years and used steroid spray intermittently. No other family or personal history was significant. On local examination, the septum was found to be deviated towards the left. Inferior turbinate hypertrophy was seen on the left. Pale pinkish smooth swelling was noted arising from middle meatus on both the right and the left side. On probing, it was insensitive to touch and not bleeding on touch. Watery nasal discharge was present in both the nasal cavities, and posterior rhinoscopy mein bilateral posterior choana was clear. All the routine blood investigations were normal, and absolute eosinophilic count was 560 cells per microliter, which was mildly elevated. On diagnostic nasal endoscopy, anterior rhinoscopy findings were confirmed. High DNS was noted towards the left, and a pale pinkish mass arising from middle meatus was confirmed. Nasopharynx was clear on both the sides. CT paranasal sinus was done, and diffuse mucosal thickening in bilateral paranasal sinuses extending into nasal cavities was noted. There was widening and obstruction of osteomeatal complex on both the sides, and thinning and erosion of the posterior wall of frontal sinus and the superior orbital ridge on the right side. It was seen to be bilateral sinonasal polyposis with suspicion of intracranial and intraorbital extension. MRI with contrast was done to confirm T1 iso intensity, and T2 hyperintensity in bilateral paranasal sinuses was noted, and T2 hyperintense peripherally inflamed mucosa with the centrally hypointensity was noted. Post-contrast, a peripheral rim enhancing lesion in the frontal lobe with intact dura was noted, and the dimensions were 15 into 18 into 12 millimeters. Neurosurgery opinion was taken in view of intracranial extension, and a provisional diagnosis of chronic rhinosinusitis with a right frontal lobe epidural abscess was made. Craniotomy with evacuation of abscess after endoscopic sinus surgery was planned. Management under informed and written consent, extensive endoscopic sinus surgery was done with right side conchoplasty, right and left wide maxillary antrostomy was done, anterior and posterior ethmoidectomy on both the sides was done, frontal sinusotomy on right and left side was done, and left and right sphenoidectomy was also done. Intraoperative findings revealed polypoidal mucosa in bilateral maxillary sinuses with fungal ball in the right maxillary sinus and in the left sphenoid sinus. There was also presence of cheesy fungal debris present in the right maxillary sinus. Post-operative course of IV antibiotics was given, and a short course of steroid was started. Histopathology revealed inflammatory nasal polyp, and heavy growth of Klebsiella pneumonia was isolated along with eosinophilia. No fungal growth was seen. Post-operative CECT was done on 8th day, and pneumocephalus in the right frontal lobe was revealed. Defect noted in the posterior wall of the right frontal sinus. Craniotomy was deferred, and the patient was advised oxygen support and IV antibiotics. Intracranial complications secondary to rhinosinusitis can present from headache to pyrexia with new onset seizures. Literature suggests that a multidisciplinary approach helps to improve the patient outcomes. For larger lesions, surgical drainage is preferred, whereas for smaller abscesses, we can manage with intravenous antibiotics and careful monitoring through serial imaging. If there is no sign of improvement, the option for neurosurgical intervention should be reconsidered. Individually tailored approach based on the size of abscess and patient's clinical status is the ideal practice. This case of frontal lobe epidural abscess due to allergic fungal rhinosinusitis with secondary bacterial infection was managed by extensive endoscopic sinus surgery coupled with a broad spectrum IV antibiotics and serial imaging. This approach can mitigate complications and can eliminate the need for craniotomy. These are my references. Thank you.
Okay, Doctor, the first reference and second reference,
Yes, sir.
you have followed what type of referencing pattern in the first and the second? Can you tell me the details? Everything was perfect in your presentation and it was good.
Yes, sir.
But I just wanted to know your perspective from the first reference and the second reference. They are two different methods of citation. If you tell this, you get a bonus point. Okay?
Okay, sir. Okay, sir. Actually, Vancouver method was followed in the second one, sir.
Okay.
In the second
First
reference.
one?
In the first reference, I did not follow the Vancouver method. I'm not sure about that.
Okay. So whenever you're trying to present, always present in one type of methodology. There's a different citation. It is mostly the American method of citations in the first one. Second one is the Vancouver's method of citation.
Yes,
And
sir.
the third one is a totally different method of citation. Okay. So
Yes.
please don't think that the judges
Other
will
than
not
Vancouver,
observe.
what else you know?
Yeah.
Yes, sir.
Other than Vancouver, what else method of citation you know?
There is
Reference
American
citation.
method of citation, sir.
Okay. Okay. Thank you. Thank you. Good presentation.
Thank you, sir.
Sir, can I ask the next candidate to start the presentation? Dr. Shailaja Gandhistri. Dr. Shailaja Gandhistri.
Sir.
Dr. Shailaja,
Dr. Shailaja
presenting,
Gandhistri.
available?
Yes, sir.
Yes,
Good
you can.
afternoon, sir. Respected sirs and madams.
Your
Today,
presentation is not.
yes, today I'm going to present a rare case report on juvenile nasopharyngeal angiofibroma. A 19-year-old male patient came with the chief complaints of bilateral nasal obstruction since 2 months, bleeding from nose since 2 months, which is a moderate in amount. Each episode lasts for about 1 minute, which regresses spontaneously. History of similar 5 episodes since 2 months. History of change in voice since 1 month, associated with snoring and mouth breathing since 1 month. History of loss of weight and loss of appetite is there. On examination, external framework of nose was normal. On tip elevation, columella and vestibule normal. On anterior rhinoscopy, a pinkish mass is seen. Pinkish mass seen in right nasal cavity at the level of middle turbinate. On posterior rhinoscopy, grayish globular mass was seen occupying the nasopharynx. Oral cavity was normal. Oropharynx showed a palatal bulge. Bilateral ear on bilateral ear examination, tympanic membrane retracted. Neck examination was normal. On diagnostic nasal endoscopy, a pinkish mass is seen below the right middle turbinate, occupying the entire nasopharynx. Mass bleeds on touch. On retrograde nasopharyngoscopy with 70 degrees endoscope, which showed a pale colored globular grayish mass is there. On CT scan of PNS, which showed right maxillary sinus with small polyps and mucosal thickening. Left maxillary sinus were showing mucosal thickening. Bilateral osteomeatal complexes narrowed. Mild deviation of nasal septum to left side. And in right nasal cavity, there is a mass which is well defined, elongated in right nasal cavity, which is extending into posterior-inferiorly into nasopharynx. Into nasopharynx with the it is extending into sphenoid sinus with polypoidal projection. Other rest of the sphenoid sinus was normal. Frontal sinus appear normal and pterygopalatine fossa normal. Orbits appear normal. Routine investigations were done. They are within normal limits. FNAC was carried out with a caution in operating table with 1 unit of blood ready. It revealed a single gray white tissue of size 1 into 0.5 centimeter. It showed well circumscribed lesion with the stratified cuboidal nasal mucosal lining. The subepithelium showed angulated blood vessels with single layer of endothelium. There was no elastin or mucosal layer. Features suggestive of nasopharyngeal and juvenile angiofibroma. Endoscope, the treatment was done. Endoscopic excision under GA. Right inferior turbinectomy was done and maxillary ostium opened. There was no mass in maxillary cavity. Mass is dissected from medial surface of medial pterygoid and mass is dislodged by firm finger dissection through oropharynx. Mass is removed and raw bone surface is felt involving the right sphenopalatine region. Hemostasis achieved and the nasal pack is applied. Post-operative period was uneventful. Specimen sent for histopathology examination, which is suggestive of juvenile nasopharyngeal angiofibroma. Coming to discussion, it is a rare tumor of benign type. It is locally aggressive tumor. It is a neovascular neoplasm, exclusively occurs in adolescent males. The incidence is 0.5% of all head and neck tumors. It is locally invasive tumor. It may spread to paranasal sinuses except frontal sinus. Pterygopalatine fossa, temporal fossa, or intratemporal.
Last 30 seconds.
Orbits and intracranial extension is also there. Yes. It is clinically diagnosed with sustainable features of recurrent epistaxis and nasal obstruction, mass in nasal cavity. Sir. These are the references, sir. Thank you, sir.
Time up, doctor.
Yeah, okay. We can take the next question. Okay.
Okay, sir.
Thank you. Thank you.
Dr. Aisha Tanyutkar. Can I start the timer, Dr. Aisha?
Yes, sir.
Can I start?
Yes, sir.
Yeah.
Good afternoon, everyone. My case report is case of infected auricular keloid secondary to the introduction. Keloids are the atypical proliferation of the scar tissue at the location of the cutaneous disruption and injury, characteristically growing beyond the original confines without any regression. It is a term derived from cheloid, which means a crab claw. It is approximately 15 times more common in the black pigmented people. It is mostly seen on chest, shoulder, upper back, neck, and the cheek. Pathogenesis, scar tissue of the keloid, present with the more prolonged inflammatory period with increased fibrinogenic factors like transforming growth factor beta 1 and beta 2, and which increases the extracellular matrix. The above process may be the reason for the keloid scar spreading beyond the margins of the original wound. Then we go to the case. A 45-year-old female presented to our department with the chief complaint of 2 swellings in the right ear pinna since 1 year, which was associated with itching, pain, and watery discharge from one vein. Asymptomatic till 1 year back, then developed the swelling in the region of antihelix first, which after the ear piercing, followed by the proliferation of the old scar at the region of the ear lobule, which was operated 6 years back. There were associated itching, pain, and watery discharge. There was no history of any fever. Past history 6 years back, for which she underwent the keloid surgery for the removal at the local hospital. No other multimodal therapy in the past. Personal history, no history of keloids elsewhere. No other comorbidities. Family history not significant. In the local examination, there was a complex sessile swelling, one on the lobule and other on the antihelix were noted, which were 6.6 centimeters and 2.5 into 2 centimeters respectively, which were oval in shape. Blackish discoloration with erythematous plaques with the irregular surfaces were noted. Clinical diagnosis of infected keloid was made and IV antibiotics were started. Investigation, routine blood investigations were done, which came as normal. Management, 3 doses of intraregional steroids, triamcinolone acetonide was given on monthly basis for 3 months. On follow-up visit, there was reduction in size, as we can see in this picture, and reduction in size as there was a reduction in size. We posted for the surgery. Informed consent was taken for the recurrence. The surgical procedure, the extent of the incision was made to assure the tension-free wound closure with incision made parallel to external helix. After that, oral antibiotics were administered for 5 days. Suture removal was done on the 10th follow-up day. 3 doses of the DAC injections were given for a period of 3 months. On the follow-up, there was no recurrence noted. This is the picture after the surgery. Discussion, there are the various treatment options such as surgical excision, intra-regional injections of the corticosteroids, comprehensive therapies, radiotherapies, laser therapies, cryotherapies. If we do only the surgical resection alone, the recurrence rate is very high, as 45 to 100%. There are several studies where multimodal therapies are used, like excision followed by combination of the steroid and radiation therapy, steroids and the silicone gel therapy, where the recurrence is less. Intra-regional corticosteroid injection can be used as a first line with a recurrence between 9 to 50%. commonly uses triamcinolone acetonide at a concentration of 40 milligrams per ml, which is given for a period of 6 months. If we are combining it with a surgery, it is given 3 months prior to the surgery, 3 months after the surgery. Then cryotherapy. Cryotherapy, we have improvement of the scar in 73% of patients with no recurrence rate. Laser therapy has been used, but with the mixed results. We use carbon dioxide, organ, Nd:YAG laser, and the pulse dyed lasers can be used. Silicone gel sheathings can be applied for after the reepithelialization, which are worn for at least 12 hours a day for several months.
Last 1 minute, Dr. Aisha. You can continue.
Radiotherapy. Radiotherapy gives the most promising result when combined with the surgery. It has a recurrence rate under 10%. We use superficial X-ray radiations as well as the brachytherapies. Brachytherapies has the upper hand. And we have therapies with anti-tumors and immunosuppressive agents like 5-fluorouracils and bleomycins. Conclusion, various treatments for keloids and emerging treatments are constantly being investigated, but there is no universally accepted regime. But combination therapies can be used for a best approach and greater, basically greater efficacy and lesser side effects. These are my references. Thank you.
All right.
Good presentation.
We have the next one. Yeah.
Sir, can I ask the next candidate? Sir, can I call the next?
Next.
Yes. Dr. Sunanda Ambati.
Next candidate.
Yes, sir. Dr. Sunanda Ambati.
Sir, I am available, sir.
Yes, sir.
Yeah,
Yeah, ma'am, you can just share your slides.
Okay, sir. Sir,
Ma'am, can you able to share the screen?
yes, sir.
Yes, ma'am. Ma'am, just a note, madam. Before 1 minute, I'll just give a ring. Make a note that still 1 more minute is there. Okay.
Okay,
so
sir. Shared, sir.
Yes, yes, ma'am. Now it's seen. Can I start the timer? When you are ready, I will start the timer. Already it is being shared, ma'am.
Okay, sir.
Yeah.
Doctor, make it full screen and start your presentation, please.
It was in full only, sir.
Make it full screen. Here.
Make it slide share and speak.
You can press that icon near that volume arrow.
Where, sir?
Right hand side bottom. Right hand side bottom.
Yes, sir.
In the PowerPoint area. No, above. Next one.
Yes.
Okay.
Can I start the timer, doctor?
Yes, sir.
Yeah. Start.
Good afternoon, everyone. Today I am going to present a case of glomus tympanicum. Introduction. Glomus tumors are highly vascular, slow-growing, benign tumors arising from paraganglionic chemoreceptor tissue distributed along the parasympathetic nerve. Glomus tympanicum is a benign and most common tumor of middle ear. It is most common in middle-aged females. Pathology in content facial nerve and bone. It has great propensity to infiltrate and invade vascular system. It is multicentric organ Glomus tympanicum, clinical symptomology, investigation, surgical procedure, and outcome. Case report: a 44-year female reported to ENT OPD with complaints of associated with ear pain and oral fullness seen on otoscopic examination. Shows moderate and grade 4 anterior posterior and 6 craniocaudal. A surgical procedure. Surgical resection is the treatment choice. Resection done through transcanal tympanotomy approach. Histopathology. Growth and rapidly advanced sections study shows a bits of human tissue with capsule and made up of multiple number of vascular channels and sheets of round cells with moderate cytoplasm and glomus tumor solid type. Surgical outcome which shows good prognosis with no recurrence or complications. Conclusion: this case report highlights the tympanicum to be included in any differential diagnosis of soft tissue mass of middle ear cavity. Surgical resection is the treatment of choice. Site and extension of the tumor decides the approach. Surgical outcomes relatively shows good prognosis with no recurrence or complications. These are the references. Thank you.
Done. Is it done, Dr. Sunanda?
Yes, sir. Yes, sir. Over, sir.
Okay.
Sir, any questions, sir, or else can you call the next question?
We can go to the next talk, please.
Next candidate.
Thanks.
Dr. Pirla Srinidhi Rai. Dr. Srinidhi Rao, be ready with your presentation. Dr. Srinidhi Rao. Dr. Srinidhi Rao, are you there?
Sir, we'll go to the next topic.
Okay, sir.
Speaker. Then
Dr. Jala Kavita. Dr. Jala Kavita, are you there?
I'm there, sir.
Yes. Can you share the slides? Sir, I think Dr. Srinidhi, she is also available, I think, sir. She just know. Okay. Kavita, you start. Dr. Kavita, you can start now.
Okay, sir. Thank you. Good afternoon, sir. I'm getting the case for one.
What? Wait, sir.
it is candidate number 10, Jala Kavita. Number 9 is not presented.
9, she's 10 is present. 10 is presenting, sir.
Yes.
Yes, sir. Dr. Kavita, are you ready?
Excuse me, sir.
Dr. Srinidhi.
Sir, there was a power cut, sir, unfortunately.
Will you present it after Dr. Kavita?
Sure, sir. Thank you so much.
Okay. Dr. Kavita, start sharing your screen.
Okay. Good afternoon, sir. I'm getting the course for one.
Start.
Okay, sir. I'm getting the A limit of nasopharyngeal carcinoma comes to the nasopharyngeal tuberculosis. It's now still when getting a QC program, the limit of nasopharyngeal carcinoma comes to the nasopharyngeal tuberculosis. Nasopharyngeal tuberculosis is a rare infectious which is responsible less than 9% in every month. Nice answer.
Dr. Kavita, you're less audible. You can speak louder, okay? Yeah, continue. Your slides are being shared.
And aggravated are available on the website and more relevant form. And complaints of violence and association, because injuries also producing nature, aggravated during the organic infection of stigma, respiratory of infections, and more relevant purpose. There is no significant past and damage. And general examination normal. A local examination, there is a normal and bilateral case, and there is a bilateral epidemic score, which is grade 1 on the right side and grade 4 on the left side. And there is HFH focus is present and major division of eye parent and lips. Arrangement is forward, but abduction and abduction tabs. And the examination faded out, left abductions, now files is same, and the relevant period of subject not. An examination notes is completely fine. At the anterior endoscopy, there is mild DNS to left inferior table head 7, left and mild mission because present. An examination is there is bilateral upper jugular digestive lymph and bilateral postparatal lymph nodes are component and right supraparatal lymph nodes are component. And ear short examination are completion normal. For diagnostic nasal endoscopy, there is a mask seen in the nasopharynx and right side. It's completely filling the nasopharynx and both right and left. And which and our bed illustrations are normal. Ultrasound like there is a multiple enlarged bilateral level 2A and level 5 lymph nodes along with the right supracover lymph nodes are bipolar. And the lymph node size of 1.98 to 1.2 centimeters seen in the right supracover level, which given infection of the rule of the neoplastic lesion and advice FNAC. In FNAC, it tells granulomatous inflammation and necrosis and for a cough physiology and advice the serum. And after the non-tax is possible. And phase 80 orbit, there is a thickening on the bilateral sphenoid surface, mucosal thickening, and along with that, there is cavernous sinus also involved, along with pituitary gland and jaw. And cavernous sinus, there is involvement of the orbital apex flow and left irregular orbital fissure to left infratemporal and ergoplateral fossa. Nasopharyngeal wall and the complete orbital infiltration also. And along with nasopharyngeal area orbital. And MRI, a mass in the nasopharynx is growing anteriorly into the nasal cavity and laterally into parapharyngeal surface and middle aspect of the nasopharyngeal surface and left retromaxillary and ergoparietal fossa with edematous pterygoid muscles and possible lytic erosions with the pterygoid plates. And extension of lead into right and left cavernous area. And this indicates we did biopsy and surgical histopathological examination and report showing us methodized granular matter inflammation. Management is the patient and anti-tuberculosis therapy and set the patient and follow. After the 6 months of therapy, patient giving got improved and nasal obstruction was resolved. And discussion. Majority of the patients of nasopharyngeal tuberculosis presents with nasal mass, nasal obstruction, rhinorrhea, epistaxis, otolgia. And the diagnosis of nasopharyngeal tuberculosis is often difficult because the nasal endoscopic evaluation and the radiological imaging will differ, offer only differential diagnosis. More common sites involve the nasal septum near the mucopollinary junction and posterior in the nasal septum. Nasopharynx is the least common site in upper respect of patient affected by tuberculosis. In case of the nasopharyngeal tuberculosis, the nasopharynx is seen in 3 patterns. Like sometimes it will be normal nasopharynx, where is differentiation and ulceration of the respiratory mucosa are followed by a mass radius erosion of cells of the nasopharyngeal tuberculosis can invade directly to the cavernous sinus at a skull base.
Dr. Kavita. Any questions, sir?
Okay. What anti-tubercular drugs were given for this patient?
The first 2 months they are given HRW, sir, and 4 months they are given HRW, sir.
Okay. Can you name? Can you name
Was
one?
there any caseous necrosis in your histopathology?
Yes, sir.
Okay. Can you name one new drug which is recently launched for management of tuberculosis?
No.
Bedaquiline. It is there. It is almost 1.5 lakhs for 1 month treatment. Okay. It is given free of cost by the RNPCP. Okay. Can we have the next speaker? Thank you, Dr. Kavi.
Sir, we'll call ninth candidate, sir, Dr. Srinidhi.
Yes.
She missed her session.
Yes, please.
Dr. Srinidhi Rao?
Yes, sir.
Yeah. Sir, she is ninth candidate, sir.
Okay.
Yes, sir.
Good afternoon, everyone. I am Dr. Srinidhi. I am going to present a case about
Dr. Srinidhi, can I start the timer?
Yes, sir. Yes.
Yeah. Now I'm starting. You can start that. Yes.
Good afternoon, everyone. My name is Dr. Srinidhi. I am going to present a case about infrahyoid flap reconstruction in glossectomy. Bhaskar, 37-year-old male, resident of Kethireddipalli, who is a carpenter by occupation, presented with complaints of non-healing ulcer with swelling over the left lateral border of the tongue since 2 months. He was asymptomatic 2 months ago when he developed swelling over the left lateral border of the tongue, which was insidious in onset and gradually progressive, had history of burning sensation, bleed from the site of the ulcer, 1 episode due to the trauma, and loss of appetite. He has no known comorbidities and has undergone excisional biopsy of the tongue 10 days ago. General examination, patient was current, cooperative, well-oriented, moderately built and nourished. On examination, an ulcer growth measuring approximately 3.5 by 1.5 centimeters on the left lateral border of the tongue, extending anteriorly 2 centimeters from the tip of the tongue, posteriorly 4 centimeters from the translingual sulcus, medially 1.5 centimeters from the midline, extending onto the ventral surface of the tongue with irregular surface and margins. Surroundings appeared normal. Palpation. Inspecting findings were confirmed.
The video. Can you enable the video of the candidate, please?
Dr. Srinidhi Rao, can you please enable your video?
We are not seeing you.
We are not
I
seeing.
understand, sir. There is a glitch, sir. So I'm not able to on the video.
Okay.
Webcam. Okay. Continue.
On palpation, the inspectory findings were confirmed. 4 centimeters by 1.5 centimeters, firm, indurated, irregular growth in left lateral border of the tongue, which is non-tender and does not bleed on touch, and is fixed to the underlying structures. Examination of the neck is normal. Provisional diagnosis: carcinoma left lateral border of the tongue with T2N0MX. This is a picture of the lesion on the left lateral border of the tongue. Tongue biopsy says squamous cell carcinoma, which is poorly differentiated. CECT neck gives a report of ill-defined homogeneously enhancing soft tissue thickening noted involving left lateral aspect of the anterior 2/3 of the tongue measuring 3 by 1.7 by 2.8 centimeters, and also multiple sub-centimetric lymph nodes, largest measuring 12 by 9 millimeters noted in the left level 3. Final diagnosis is poorly differentiated squamous cell carcinoma, left lateral surface tongue, T2N0M0, which is stage 2. Treatment plan is left glossectomy, type 2, partial glossectomy with neck node dissections 1 to 4 levels with infrahyoid flap reconstruction. Procedure, the lesion is marked with adequate margins and excision is done, leaving a defect of 4 by 3 centimeters, infrahyoid flap of 7 by 4 centimeters, Flap is harvested with straps intact. Neck node dissections done, level 1A, 1B. For 2A, 3, 4, and 2B were dissected. Intraoperative findings, mouth opening adequate, no ankylosing, and no suspicious nodes were detected, and it was closed over 14 number suction drain. These are the specimens sent for histopathological examination. The report was moderately differentiated squamous cell carcinoma with the PT3 N1 staging. Poorly differentiated squamous cell carcinoma of the tongue is aggressive form of cancer. Infrahyoid flap reconstruction is a reliable technique for the reconstruction of defects following partial glossectomy. Anatomy of the infrahyoid flap. It is a regional myocutaneous flap consisting of the following components: muscles, including infrahyoid muscle, sternohyoid, sternothyroid, and sometimes omohyoid. Blood supply is by superior thyroid artery, venous drainage through superior thyroid vein, nerve supply by ansa cervicalis. Indications: infrahyoid flap is used in partial glossectomy defects, small to medium defects following resection of the tumors, cases where free flap is not feasible due to comorbidities or resource constraints, T1 or T2 squamous cell carcinoma of the tongue where there is need for local flap reconstruction. Advantages: by reliable, because it has a reliable blood supply which is superior thyroid artery, which reduces the risk of flap necrosis. Relatively simple technique and a good functional outcome. And there is also, it is harvested from the same operative field, reducing the donor site morbidities. Disadvantages: it has a limited reach and size, suitable for small to medium defects only. So larger defects require free flaps. And aesthetic concerns: donor site scar on the neck may be visible, and risk for dehiscence or fistula.
Dr. Srinidhi.
Yes, sir. Yes, sir. Reduced tongue oblique. That's it.
Srinidhi,
Yes, sir.
what else flap can use, locally available flap you can use for reconstructing these defects?
The other flaps that can be used for reconstruction, sir, are radial forearm free flap, anterior thigh flap, pectoralis major myocutaneous flap, submental island flap, sir, temporalis muscle flap.
Okay. Have you heard about FAM flap? FAMM?
Sir?
FAM flap, FAMM?
The
facial artery myomucosal flap?
Yes.
Okay, no problem. Okay. Okay, sir.
Thank you.
Thank
Sir,
you,
can
sir.
we proceed with the Sir, can we proceed with the next
Yes,
presenter?
please. Yes.
Dr. Shaista Ifat.
Yes, sir.
Dr. Shaista, any other connections are there in your room? Because it's echoing. Okay.
Yes.
Are you ready?
Just a second, sir.
Okay.
Good afternoon, everyone. My name is Dr. Shaista. I'm presenting a case on thyroglossal cyst. So, an 8-year-old female child presented to ENT OPD with chief complaints of swelling at the base of the tongue since 1 year. And history of present illness. The patient was apparently asymptomatic 1 year back. Then she developed swelling at the base of the tongue, which was insidus in onset, gradually progressed to the present size. There was occasional pain during swallowing. Past history, the child was not increasing in height as compared to increasing age. Then the parents consulted an endocrinologist and the routine investigations were done. Later diagnosed as juvenile hypothyroidism or autoimmune thyroiditis. Personal history, the diet was mixed. Personal history was normal. Next, general examination. The patient is conscious, coherent, and cooperative. The height of the child was 119 centimeters and the weight was 23 kgs. So according to WHO growth charts, the height was less than 3rd percentile. There was no pallor, icterus, clubbing, no lymphadenopathy, no generalized edema, and the vitals were stable. Systemic examination was normal. On oral examination, the angle of the mouth was normal. The mouth opening was normal. The gums and teeth were normal. Anterior 2/3 of the tongue was normal. So on the posterior part of the tongue, a small round, soft, painless swelling of the size 1 into 1 centimeter was seen at the base of the tongue. The smooth surface with a well-defined margins. The swelling does not move on protrusion of the tongue. On neck, there were no cervical lymphadenopathy. And the rest, the ear and nose examination, there were no abnormalities found. So on basic investigations, her serum TSH levels were 23.56 and her serum T3 levels were 75.96 nanograms and serum TSH was 7.2. And her anti-TPO antibodies were 419.51 international units. On CCT neck, a round, well-defined, thin-walled, hypodense, non-enhancing, hypo-enhancing with thin interceptations noted in the posterior part of the tongue in midline. The size of the lesion was 18 into 18 mm, suggestive of likely thyroglossal duct cyst. The thyroid gland grossly was normal to her age. This was the image, sir. And on 99 technetium scan, both lobes of thyroid are normal in size with normal tracer uptake. The salivary glands and the background uptake appears physiological. There were no evidence of any focal cold or hot area in both lobes. No other area of abnormal tracer uptake noted in oral cavity, neck, and upper mediastinum. The thyroglossal cyst noted on CCT scan does not have any functioning thyroid tissue. This was the image of technetium scan. And next, the differential diagnosis, the ranula and lingual ectopic thyroid and benign and malignant tumors. So the planned excision of the thyroglossal cyst by transoral approach after normalizing the serum TSH levels. Discussion. The thyroglossal duct cysts are the most frequent occurring congenital cervical abnormalities. They can form anywhere along the thyroid route of migration from foramen cecum in the tongue to the thyroid location in the neck. The thyroglossal duct is a normal tubular structure that connects the thyroid gland to the foramen cecum. The distal part of the duct differentiates into the pyramidal lobe of the thyroid gland in about 50% of the people. The thyroglossal duct normally involutes by 10th week of gestation. If any portion of the duct persists, the secretions from the epithelial lining can result in inflammation and thyroglossal duct cyst formation. They are often asymptomatic and, however, can present as an abscess. Sir. Hello. Sir, it's
Hello?
done. Sir.
Yeah, it's done. Okay.
Okay. This child was not operated, doctor.
Sir?
Was this child operated?
No, sir.
Okay. So
her serum TSH levels were very much high, sir. So what they suggested was to normalize the levels, then we can take for surgery, sir.
Okay. What are you planning to do? What surgery are you planning to do? After the TSH is normalized, what surgery are you planning to do, doctor?
Thyroglossal duct cyst excision, sir, by transoral route.
What is the name of transoral route? What is the name of the surgery called?
Cyst trunk operation, sir.
Is it done transoral or?
How do you? Okay, ma. Thank you.
Okay. Thank you.
Okay, sir. I'll call with the next one. Dr. Sheikh Mona. Dr. Yeah.
Yes.
Start sharing.
Good afternoon. I'm Dr. Sheikh Mona. My case is about the classical presentation of Trotter's trial in carcinoma of nasopharynx. A 56-year-old male patient presented to ENT OPD with chief complaints of nasal blockage since 3 months and difficulty in breathing since 1 month. History of present illness, patient was apparently asymptomatic before 3 months, noticed nasal blockage and difficulty in breathing, aggravated during the lying down position. History of ear discharge, which is continuous, greenish in color, subsided on medication, but associated with difficulty in hearing. History of headache, left-sided, including entire face, continuous, present throughout the day, not relieved on the medication. There's a history of epistaxis 2 months back, 2 episodes, scanty, and relieved on medication. No history of diplopia and no history of epiphora. Past history, it's a known case of hypertension and diabetes mellitus since 20 years and on regular medication. Not a known case of CAD, severe epilepsy, and chronic liver disease and is chronic smoker since 15 years, 3 to 4 cigarettes per day, stopped 5 years ago, and gutka chewer since 20 years, stopped 5 years ago. No surgical history in the past, no history of drug allergies. Personal history, everything is normal. The general examination, patient is conscious, coherent, moderately built, no pallor, no icterus, no clubbing, no lymphadenopathy, no generalized edema. Right-sided deviation of mouth is the same. This is a figure showing the right-sided deviation of the mouth. Systemic examination were normal. In cranial nerve examination, right-sided deviation of mouth is available. Cranial nerve 7 involvement can be seen. ENT examination, external nose is normal. On anterior rhinoscopy, no abnormality is detected. Posterior rhinoscopy, pinkish mass is seen obstructing the eustachian tube opening. Paranasal sinuses, bilateral frontal, ethmoid, and maxillary are non-tender. Functional test, cold spatula test, mist formation is decreased on the left side. Cotton wool test, absent movement of fiber on the left side. Ear examination, right ordinary, external auditory canal and tympanic membrane is intact. Left external auditory canal is normal. Tympanic membrane is retracted and bulged. Oral cavity examination, angle of mouth is deviated to right side and lips mouth opening is normal. Soft palate, left-sided decreased movements of this soft palate can be seen. Uvula is deviated to the right side. Oropharynx is normal. Routine blood investigations were done, it's normal. And diagnostic nasal endoscopy, septum is midline and floor of the nose is normal. Nasopharynx on the left side shows pinkish mass, bleeding on touch. Right side nasopharynx is normal. Biopsy was taken from the mass and sent for the histopathological examination. DNA showing the mass in the nasopharynx region. On CT scan, left nasopharynx shows ill-defined heterogeneous mass lesion extending anterior superiorly into the sphenoid sinus with loss of bony outlines. Laterally, there is loss of sphenoid sinus walls with intracranial extension into the temporal lobe. Posteriorly, there is destruction and widening of the pterygoid plates, involvement of the sylvus, inferiorly extending into the torus tubaris, Eustachian tubes, and fossa of Rosenmuller. Approximate measurements are 40 mm into 42 mm, suggestive of neoplastic etiology. These are findings of CT scan. Histopathological examination shows squamous cells individually showing pleomorphism with moderate amount of eosinophilic cytoplasm and individual cell keratinization. Plenty of keratinization on the surface and the keratin pulse noted in the between of sheets of squamous cells. Features suggestive of keratinizing squamous cell carcinoma. Pure tone audiogram was done. Left ear shows both conductive and sensory neural hearing loss. Right ear, mild sensory neural hearing loss. Differential diagnosis with enlarged adenoids, HIV-associated lymphatic hyperplasia, inverting papilloma and vascular malformation, non-Hodgkin lymphoma and nasal polyposis. Management, further investigations are needed to be done for like contrast enhancer CT scan, MRI to know the extent of involvement. MRI imaging is recommended for the staging of the nasopharyngeal malignancy. CECT is preferred for the cervical metastasis. Chemotherapy is the main modality of the treatment. Intensive modality radiotherapy is a new method of radiation delivery which is becoming increasingly used to treat the nasopharyngeal carcinoma. On discussion, Trotter's triad is characterized by the mostly deep ipsilateral pain due to the fifth cranial nerve involvement, ipsilateral conductive deafness due to eustachian tube obstruction, and ipsilateral soft palate immobility is due to the involvement of the cranial axillary nerve. Adult patients with unilateral resolving otitis media with F have to be proved to NMC until proven otherwise.
Time.
Doctor, what are the classical signs for Trotter's triad, doctor? Can you tell me?
Yes, classical signs are conductive deafness on ipsilateral side and ipsilateral deep one-sided pain, including the temporal and including facial pain, and soft palatal paralysis.
For your patient, what did you suggest? Radiotherapy?
Actually, we were referred to the higher centers for CECT and MRI.
Yes.
We mainly suggested for chemotherapy, sir.
Okay. Normally, we suggest radiation therapy because the tumor melts on radiation therapy. That is what is the characteristic description of the case. All right.
Yes.
So, are you following up this patient?
Sir?
Are you in follow-up with the patient?
Yes, sir. We are on the follow-up, but the patient did not respond. We are again trying to follow up in the.
What histological pattern was exhibited in this case?
Keratinizing squamous cell carcinoma, sir.
Okay. Okay. Thank you.
Okay, thank you, sir.
What is the modality of management in nasopharyngeal carcinoma?
Chemotherapy is the main modality, sir, with the cisplatin. Recently, radiotherapy, including with the chemotherapy, both can be used to, depending upon the extent of the involvement, we can use both radiotherapy and chemotherapy.
What is Guangdong tumor?
Which means
Nasopharyngeal carcinoma only. It was more prevalent in Guangdong province of China. Okay. Is there in spot brown?
Okay, sir.
Okay, thank you.
Okay, thank you, sir.
Ask the next candidate to present.
Okay, sir, we can have the next.
Yes. Dr. Asma Begum. Yes.
Hello, sir.
Yes, doctor.
Hello,
Start.
sir.
You can start, doctor.
Good afternoon. Good afternoon, sir. Myself, Dr. Asma Begum, presenting you a case report of intralaryngeal lipoma, sir. Introduction: lipoma. It is a benign mesenchymal tumor composed of fat cells. It is commonly present in 4th to 6th decades. Intralaryngeal lipoma, it is exceptionally rare benign tumor. It constitutes only 1% of all lipomas. Less than 130 cases reported in literature. It originates from adipose tissue within the larynx. It can cause dyspnea and dysphonia and such mimic carcinoma larynx. Presentation: a 47-year-old male, a non-smoker with no known comorbidities, presented to the outpatient department of otorhinolaryngology with complaints of change in voice for 2 months. There was no history of pain in the throat, no history of fever, no history of breathlessness or strike. On examination, general and systemic examination was normal. On indirect laryngoscopy, submucosal swelling 2 by 1 centimeters in an area above the right false spots in a supraglottic region is seen. On video laryngoscopy, sessile even lesion of 2 by 1 centimeters is seen in an area between ariepiglottic folds and false spots of right side. In the supraglottic region, the homolateral vocal cord was partially obscured and its mobility was limited due to the mass effect principally on the homolateral arytenoid. Coming to investigations, we have done CCT neck, in which a well-defined lobulated fat attenuated lesion of 22 by 15 by 14 mm seen in the posterior part of larynx, laterally abutting right vocal cord or arytenoid cartilage and posteriorly abutting cricoid cartilage. Features are suggestive of intrinsic laryngeal lipoma. On contrast, no enhancement was seen. Come to discussion. Overall imaging and clinical findings are compatible with lipoma of the supraglottic region. Lipomas are the most common benign mesenchymal tumors seen in 4 to 6 decades. Subsides are tonsils, tongue, parotid gland, and palate. Clinical features include dyspnea, sleep apnea, snoring, paroxysmal coughing, dysphagia, and airway obstruction. Laryngeal lipomas are further classified into intrinsic lipomas and extrinsic lipomas. Intrinsic lipomas involve aryepiglottic false vocal cord and the epiglottis, whereas extrinsic lipomas involve piriform sinus and lingual surface of the epiglottis. Ours is intrinsic lipoma. And the 4 main differential diagnoses for lipoma. Lipoma, there is complete fat suppression is seen, lack of septations, no enhancement on histopathological examination, adipocytes of varying sizes and macrophages are seen, whereas liposarcoma, hemorrhage and necrosis are seen. Angiography aids in its differentiation due to its hypovascularity. On histopathological examination, lack of macrophages and variation of adipocytes is seen. Hibernoma, lipomatous lesions seen in middle-aged patients consisting of brown fat. On CT, hibernomas are well-circumscribed lesions with attenuation between skeletal muscle and fat. Whereas lipoblastoma, it is rare. It is a tumor that arises from embryonic white fat. It presents in infancy and early childhood. It occurs in the trunk and extremities. Microlaryngeal surgery with complete excision of tumor was done using skimmer laryngeal bed. It is sent for biopsy, which showed mucosa lined by stratified squamous epithelium, and submucosa showed mature adipocytes, which is suggestive of lipoma. Here is my HP report attached. Follow-up. Postoperatively, patient's voice was improved and he recovered well at 2-month follow-up. Patient is still under observation, sir. Take-home messages of my presentation are being aware of laryngeal lipomas, as they can cause acute larynx obstruction. As a mimic carcinoma larynx clinically differentiate from it. Important to differentiate it from other laryngeal masses like liposarcoma. Imaging is important as some regions may be obscured by mass. Proper histopathological examination post-removal is crucial. Post-op follow-up is essential to detect recurrence. So complete excision of the tumor has to be done to avoid any recurrences. Patient consent. Written informed consent was obtained from the patient for publication of this case report, including accompanying images, sir. Here are my references, sir. Thank you, sir.
Yeah, thank you.
Thank you, sir.
What were the challenges in your case to handle this patient?
Sir?
What were the challenges? Was it diagnostic challenge or surgical?
Sir, both, sir. Actually, patient presented with hoarseness of voice, sir. So we thought it may be a CA larynx. But on CT we could find it as it is lipoma, sir. And during surgery, we did it with the laryngeal skimmer blade, sir. We would have done it better if we have CO2 laser, sir. Taking care of the vital structures, this is essential during surgery, sir.
Do you have narrowband imaging in your institute?
No, sir.
Okay. What would narrowband imaging done if you had it?
Sir?
What is the role of narrowband imaging here? Is there any role of narrowband imaging? Any role of narrowband imaging in your case?
Thanks.
Okay, doctor. Thank you.
Nice presentation. Nice slide.
Itself, for sure.
The next candidate, sir.
Okay, okay.
Oh, yes, please. Next, please.
Apeksha Raj.
Hello. Yes.
Yes. Yes, Dr. Apeksha Raj.
So 1 second, I'm sharing the screen.
Yeah. Yes, it's visible.
Good afternoon, sir. I'm Apeksha Raj, and I'm presenting a case of adenoid cystic carcinoma of the nasal septum. Adenoid cystic carcinoma is a very rare cancer of the head and neck that primarily occurs in the salivary glands. But it's not just exclusive to the head and neck. It can also arise in other locations such as respiratory tract, esophagus,
Can you
breast, and
maximize your
Can you make
slides?
it full screen, please? Full screen slide share.
It is on full screen.
Yes.
Yeah. Okay.
So it is not just exclusive to the head and neck. It can also arise in other locations such as respiratory tract, esophagus, breast, and genitourinary system. Coming to the head and neck, it most commonly arises from major and minor salivary glands, which accounts for approximately 3 to 5%. But in the nasal cavity, it is very rare. And even if it occurs, the most commonly it arises from the lateral wall of the nose. Histologically, it is a pseudo-stratified columnar epithelium. It is a very slow-growing tumor, but has a high tendency for perineural invasion and local recurrence. Distant metastasis through hematogenous spread to lungs, bone, and liver is common. Lymphatic spread is very rare. The risk factors are it has autosomal dominant inheritance, and radiation exposure is one of the other risk factors. Coming to the case history, a 41-year-old male patient came to us with complaints of left-sided nasal obstruction since 1 year, frequent bleeding from the left nostril for 6 months, swelling on the left side of the nose since 4 months. The patient was apparently asymptomatic 1 year ago when he developed left-sided nasal obstruction, insidious in onset, gradually progressive, constant, with no aggravating or relieving factors. Epistaxis, he had frequent episodes of bleeding from the left nostril since 6 months, approximately 20 to 30 episodes, each episode lasting for about 30 seconds, and the bleeding stopped on applying pressure. He noticed a painless swelling on the left side of the nose since 4 months, insidious in onset, gradually progressive, no aggravating or relieving factors. There's also a history of hyposmia, hyponasal speech. There's no history of nasal trauma, nasal surgery, no history of nasal discharge, postnasal drip, atopy, or recurrent sinusitis. Past history, there were no similar complaints in the past. He had no other comorbidities, no surgical history. Family history was not significant. Personal history was normal. General examination was normal. Coming to ENT examination, nose, on inspection, there was a reddish polypoidal growth occupying the entire left nasal cavity. On the external nose, there was fullness over the left alar region and left dorsum of the nose. On anterior rhinoscopy, there was a pinkish red mask in the left nasal cavity. Palpation. Disconnected.
We can hear you, Dr. Apeksha. We can hear you. Go on.
Sorry.
No problem.
Probe test inspectory findings were confirmed. It was firm, bleeding on touch. Probe could be passed all around except on the medial side. Cold spatula test on the left side, it was decreased. Cortals test was negative on both sides. Cottonous test was decreased on left side. Posterior rhinoscopy could not be done. Ear and throat examination was normal. Neck, trachea, central neck examination, no palpable lymph nodes. Everything else was normal. Investigations, CECT PNS was done. On this, a well-defined heterogeneously enhancing soft tissue attenuating lesion with epicenter in the left nasal cavity involving the septum, middle turbinate, and ethmoidal sinus was seen, extending till the left osteometal complex of the left maxillary sinus. There was also thinning and destruction of the bony nasal septum, lamina papricia, bony septum of the left ethmoidal sinus, posterior wall of the frontal sinus, maxillary sinus, and anterior wall of the left sphenoid sinus. Features were suggestive of neoplasia. There were also features suggestive of sinusitis. A provisional diagnosis of a tumor of vascular origin was made. Therefore, biopsy was not attempted in the OP. Coming to the treatment, we did an excisional biopsy under general anesthesia using an endoscope. Intraop findings were a large irregular mass filling entire nasal cavity with attachment to the septum. There was also atrophy of the middle turbinate, bleeding from the septal attachment, and there was thick mucopus in the maxillary, frontal, and sphenoid sinus. Post-operatively, radiotherapy was done. Histopathology report, focally ciliated columnar epithelium with an underlying neoplastic lesion showing a biphasic architecture with ductal and myoepithelial cells was seen. The cells were seen in cords and nest with oval to angulated hyperchromatic nuclei. The features were suggestive of adenoid cystic carcinoma, cribriform type. This was a post-op endoscopic PIC and post-op PNS. Conclusion: even though adenoid cystic tumors in the nasal septum are a rare entity, regardless of this fact, it should be considered as one of the differential diagnoses of nasal tumor because of its noted nature of
Time up, doctor.
recurrence. Yes.
Okay, doctor, what is the classical microscopic appearance which you can see in adenoid cystic carcinoma?
Ductal and myoepithelial cells are seen, sir. There are three types of histological types, sir: cribriform, tubal, and solid. In this case, cribriform, which is less, it has a good prognosis compared to solid, sir.
So, in your case, there was only involvement of the cartilaginous septum, not the bony septum, correct?
Yes, sir.
So, it would not cause much of a problem. But did you retain the caudal and the dorsal strut? The patient did not develop any supratop deformity or any deformity
No,
post
sir,
surgery?
he didn't develop any deformity, sir.
So, suppose this patient had an extensive involvement even of the cartilage and bone, how are you planning to address it? If this patient had an aggressive pattern, say the patient who proposed this classification, solid, tubular, and cribriform, just the name if you can tell me. I'll give you one extra mark.
Not aware of it, sir.
HM's proposed this classification. He classified it as it was somewhere in 1856, somewhere, okay? And solid cribriform and tubular pattern. Solid has a very poor prognosis, and it has a Swiss cheese pattern. This is what I wanted to.
Sir.
Yeah, that
Yes,
is what I
switch
see.
stage pattern. Yes.
If there was involvement of the nasal bone, we can do a cantilever technique. We can put the plates and screws from the residual dorsum or the nasal part of the frontal bone and give a patient a projection, right?
Yes.
Because sometimes there is involvement of the cartilage. The entire cartilage is removed, means there can be deformity.
Yes.
What margins were taken for this lesion? Any margins?
Margins were
What
negative,
margins?
sir. 5 to 10
What
mm.
margins did you take? 5 to 10. Okay. Right. Thank you.
Thank you. Okay.
Thank you, sir.
Sir, can I call the next candidate, sir?
Yes, please.
Yeah. Dr. Benita John.
Yes, sir. I'll share my slides, sir.
Yeah.
Shall I start, sir?
Yeah.
Good afternoon, respected sirs and ma'ams. My topic today is
Make it
mucoepidermoid
full
cell.
Can you
screen, doctor?
maximize?
Make it full screen. Slide share. Press F5 on your keyboard. Doesn't seem to come. There is a play button, orange color in the down aspect of your screen.
Yes, sir.
Orange color, close that.
Yes, sir. I'll start, sir.
Yeah.
My topic today is mucoepidermoid carcinoma of submandibular salivary gland. Salivary gland
Not yet.
neoplasm.
Not yet. It's not come.
Not yet.
Otherwise, next to the next to the play, there is one other button.
Book.
Just click on that. Yeah. Just click on that. Does it appear?
Before that, sir. Book lab.
No, it is not appearing. Just press the play button. No, it goes to somewhere else. Okay, go to the slideshow in the screen above. Home, insert, design. Click on slide share, slideshow above. Then you can start.
Is it okay, sir?
No. Maximize. Full screen. Full screen.
Full screen.
this.
Any problem, doctor? Are you able to
Sir,
get it?
full screen, I'm pressing slide share, sir. It's coming like this.
Okay, let's proceed.
Okay.
If it's okay. Yeah.
Continue.
Good afternoon, sirs. My topic today is mucoepidermoid presentation at submandibular salivary gland. Submandibular salivary gland account for 5% of the total salivary gland neoplasms. In that, mucoepidermoid is most common in parotid salivary gland, but least common in submandibular salivary gland. It arises from pluripotent cells of excretory ducts of gland. Histologically, the tumor is composed of epidermoid cells, mucus
Doctor,
cells.
slides are not being like
visualized.
It's not like what you are reading cannot be seen either.
I'll once again share, sir.
Yes, doctor. Now it's full.
It is better now. Very good. Okay, please go ahead.
Good afternoon, sirs. My topic today is mucoepidermoid carcinoma at submandibular salivary gland. Salivary gland neoplasm account for approximately 5% of all neoplasms. Mucoepidermoid carcinoma is most common salivary gland tumor in parotid and least common in submandibular gland. It arises from pluripotent cells of excretory ducts of the gland, and the tumor is composed of epidermoid, mucus, and intermediate cells. It is therefore a malignant tumor, which is a mixture of epidermoid and mucus cells. Histopathologically, the tumor is classified into low, intermediate, and high. The intermediate is least common, while the low grade is the most common. In this case history, a 36-year-old female patient came to the ENT outpatient department with chief complaints of painless swelling in the left side of jaw along the body of mandible since 2 years. On examination, on systemic and general examination, everything was normal. On local examination, an ovoid swelling of size 2 into 1 cross 2 into 1.5 centimeters seen in the left submandibular space. It is smooth, firm in consistency, non-tender, mobile, and skin over the swelling is normal. There are no other swellings or no other lymph nodes in the cervical region. Next, on routine blood investigations were all within normal limits. On radiological investigation, first ultrasound neck was done. It is found to be a well-defined cystic lesion, which is of size 14 cross 14 mm, noted in the left submandibular region. And on FNAC report, there was seen eosinophilic, amophilic, proteinaceous material with cystic macrophages and lymphocytes. Very few clusters of benign epithelial cells were seen. Cytological appearance is suggestive of cystic lesions. On preoperative CT, there was also seen well-defined isodense lesions with the central hypodense lesion of size 10 cross 12 cross 12 mm noted in superficial part of left submandibular gland. On contrast administration, the lesion shows mild peripheral enhancement with central non-enhancing hypodense area. On intraoperative pictures, this is the intraoperative pictures, and the procedure planned was submandibular gland excision. Incision is made, a transcervical excision. Incision is made in the skin submandibular region, 5 to 8 centimeter length, parallel to the body of the mandible. The incision is further deepened to deep fascia to expose the capsule of submandibular gland. Subplatysmal planes are not raised, and posteriorly the facial vessels are ligated. Lingual and hypoglossal nerves are preserved. Since postally we can see any damage to tongue, so they are preserved first. And mylohyoid muscle is retracted to remove the deep lobe. Hemostasis is secured and drain is placed in situ. This drain is removed after two days. While assessing the blood collection, it should be less than 30 cc within 36 hours. So on histopathology, the 1.5 into 1.5 centimeter lesion filled with mucin was present. The surrounding fibrotic area showed mucoid cells with abundant eosinophilic cytoplasm. There was no evidence of perineural invasion. Tumor is also seen infiltrating submandibular gland and the margins are free. So thereby the pathological staging is low-grade mucoepidermoid carcinoma with T1, N0, M0. There are 3 grades: low grade, intermediate grade, and high grade. Low grade is calculated as 0 to 4, intermediate 5 to 6, and high grade is more than 7. These are based on cystic components less than 20% and neural invasion are given 2 points. Necrosis and cell mitosis are given more than 3 points and the anaplasia is given more than 4 points. And in this slide, if we are seeing, there are more mucoid component. So thereby it is a low-grade epidermoid carcinoma. And the discussion is mucoid epidermoid CA is a common malignant tumor of the submandibular salivary gland. Not all diagnostic features can be seen on FNAC, especially in low grade. Hence, it can be confused with other malignant lesion. When epidermoid component constitutes, like predominates, the histological appearance is similar to squamous cell CA and is considered to be high grade. It is considered low grade when mucin secreting cells are predominant, like this case. In this case, in the previous slide, as we have seen, mucin cells are more. And the epidermoid component is more, means it is considered to be high grade. Mucoepidermoid C is rarely found in submandibular. Only 6 to 11% is found in submandibular gland. Hence, it is a rare case report. In parotid gland, it is more commonly present because mucin producing cells are more commonly seen in parotid gland. So thereby, this case report exemplifies the FNAC findings and adds to the existing findings of this mucoepidermoid C of submandibular gland. These are my references. Thank you, sir. It's over, sir.
Yeah, very good. What are the key factors which influence prognosis for your case?
Histological features, sir. First, in histological features, it should be low-grade CA, sir. Low-grade means there should be less cell mitosis and no perineural invasion and no necrosis, no anaplasia. These histological features favor more good prognosis. And next, epidermoid component should be less, same as histological features, sir.
Okay.
Okay. Good presentation. Thank you.
Okay, thank you, sir.
Hello. Can I call the next candidate, sir?
Yes, please. Next.
Dr. Kudram Adil Hashmi.
Hello. Good afternoon, sir.
Yes, doctor. Can I start the timer?
Yes, sir.
Yeah. Start.
Good afternoon. I'm Dr. Khurram Adil Hashmi, and I'll be presenting a case on Pott's Puffy tumor with pansinusitis. A 16-year-old male patient came to the ENT OPD and presented with right forehead swelling and periorbital edema since 3 days. Hello? Am I audible, sir?
Go on, doctor.
The patient was apparently all right 3 days ago when he developed right-sided swelling on the forehead.
Can others be muted, please? Those who are
next is 18, 19th.
Ramesh sir,
Your mic is on, sir.
Yeah, I have muted. It's okay. Carry on.
Yeah, the patient was apparently all right 3 days ago when he developed right-sided swelling on the forehead since 3 days. The patient also developed right-sided periorbital edema, which led to the inability of opening the right eye. There was history of post-nasal discharge and history of allergic symptoms. No history of epistaxis, no history of recurrent URTI. Past history, not a known case of hypertension, coronary artery disease, diabetes mellitus, epilepsy. No history of surgeries in the past. Personal history, diet mixed, appetite normal, bowel bladder habit regular, sleep disturbed, and no history of addictions. As cocaine addiction might sometimes lead to Pott's Puffy tumor. General examination was normal. Systemic examination was normal. On ENT examination, no external deformity was seen. On anterior rhinoscopy, nasal septum was in the midline. Right inferior turbinate hypertrophy was present. Ear examination was normal, and oral cavity examination was normal. Functional test, smell sensation present on both sides. Cold spatula test was normal, and cotton wool test was normal. On examination of the eye, the patient was unable to open the right eye, and there was swelling and tenderness present in the right eye. On diagnostic nasal endoscopy, nasal mucosa congestion was present, and right middle and inferior turbinate hypertrophy. First hour ESR was 110 millimeters. On CT scan, complete opacification on CT scan of the paranasal sinuses, there was complete opacification of right frontal and ethmoid sinuses with broadening and opacification of anterior osteomiatic.
Dr. Adil.
I
Dr.
think,
Adil?
Stop that, sir.
Power cut, sir.
I think any power cut, sir? Sir, there is a power cut with him, I think, sir. Message.
We will go to the next
We'll
candidate.
go the next candidate, sir. Again, when he comes back, we'll start him.
Yeah. Okay.
Dr. Ramani Manasa? Dr. Ramani Manasa?
Can we go to the next, sir?
Yes, sir. Yes.
Sriharsha.
Dr. Sriharsha, are you available?
I'm sorry, sir. There was a power cut and I
Yeah.
connected.
Dr. Purna.
Yes, sir.
Yeah.
Yes, sir.
You can start from the same slide.
Yes, sir.
Already 2 minutes, 15 seconds have been over. You are given still the rest of the time. Okay.
Yes, sir. On CT scan of the paranasal sinuses, there was complete opacification of right frontal and ethmoid sinuses with broadening and opacification of anterior osteomeatal complex, sinonesis, complete opacification of right maxillary sinus with broadening and opacification of the maxillary ostium, and pansinusitis was seen. These are the images of the CT-PNS, sir. And the first surgery was performed on the
Just
patient.
go to your previous slide, just a minute.
Yes, sir.
Why are the images inverted?
Hello, sir.
The images are inverted, the CT-PNS. Okay, proceed.
Coming to the discussion, the Pott's puffy tumor is a rare but potentially deadly complication of bacterial sinusitis that consists of subperiosteal abscess and osteomyelitis of the frontal bone. It is best diagnosed with a computerized tomography with intravenous contrast and magnetic resonance imaging and treated with early broadening spectrum antibiotics and surgical intervention. The condition is important to diagnose early, as complications of the tumor can result in meningitis, frontal lobe abscess, cavernous sinus thrombosis, and epidural and subdural abscess. Symptoms can vary from headache, periorbital swelling, swelling of the forehead to purulent discharge, cutaneous fistulas, altered mental status, and cranial nerve deficits, but fever can be absent. Pansinusitis is a condition in which all the paranasal sinuses are inflamed. Some of the symptoms may cause headache, fatigue, pain, pressure around the cheeks, eyes or nose, sore throat, fever, ear pressure, difficulty breathing, yellow or green discharge from the nose. The causes can be bacterial, viral, or fungal infection. There could be increased risk of hay fever, allergies, asthma, nasal polyps, tumors, or respiratory tract infection, aspirin sensitivity, etc. if not treated early. The differential diagnosis of Pott's puffy
Yes,
tumor
doctor.
could be.
Time up, doctor.
Okay, thank you, sir.
Sir, any questions, sir?
How do you manage this condition, doctor?
With surgical intervention and then.
What surgery are you planning to do?
We performed a first surgery, sir.
Okay.
Yes,
How
sir.
did you approach the frontal sinus? What approach was done? What was your approach to the frontal sinus in your case? All right. So we'll go to the next candidate. Yeah.
Thank you, sir.
Sir, candidate number 17, she's not presenting, sir. So we can go with the next candidate, sir. Just now she informed us. So we'll proceed with the 18th candidate, sir.
Okay. Number 17 is absent.
Number 17 is absent, sir.
Okay. Right.
18, Dr. B. Sriharsha.
Yes, sir. Good afternoon, sir.
Wait. Can you make it maximize slides?
Yes, sir. Please. Shall I start?
It's not. Is it the first slide?
Yes, sir.
Okay. Now you can start.
Okay, sir. Good afternoon, sir. The presentation is about maxillary nerve schwannoma, which is a rare case. Introduction: schwannomas are the benign tumors arising from the Schwann cells that encase the cranial nerves as they abscond the central nervous system. About 1/3 of all the schwannomas occur in the head and neck region, and they are in the paranasal rare. Etiology is unknown. The lesion presents as a nasal obstruction, dysphagia, and hoarseness, depending upon the site of the lesion. The treatment is complete surgical excision of the benign tumor, followed by the post-operative histopathological examination to establish the final diagnosis. These tumors can occur anywhere in the body, but relatively common in the head and neck region, but the involvement of sinonasal region is commonly seen in the ethmoid sinus, followed by the maxillary sinus, nasal cavities, and the sphenoid sinus. My case presentation: a 35-year-old female patient presented to the Department of Otorhinolaryngology with 1 month history of pain and numbness over the left side of the face, which was insidious in onset and progressive in nature. She also complained of left eye pain and left upper molar tooth pain. On examination, the general and systemic examination was normal. On local examination, there was a grayish-white firm mass in the left nostril, which was pushing nasal septum to the right side. On ophthalmic evaluation, showed bilateral normal vision, normal visual field, and normal eye movements. There was no significant cervical lymphadenopathy, and the intraoral examination was normal. On investigating, we did a contrast-enhanced CT scan of the paranasal sinuses, which showed a dumbbell-shaped hypodense lesion noted in the left masticator space, extending superiorly along the course of left maxillary nerve into the middle cranial fossa, causing expansion of the foramen rotundum and extending up to the lateral aspect of the left cavernous sinus. The lesion is measuring 53 into 28 into 30 mm and causing mass effect as described. It's likely a maxillary nerve schwannoma. The further evaluation, we even did a contrast MRI of the paranasal sinuses, which showed a dumbbell-shaped hyperintense lesion noted in the left masticator space between medial pterygoid and masseter muscle, extending superiorly along the course of left maxillary nerve into middle cranial fossa. Causing expansion of the foramen rotundum up to the lateral aspect of left cavernous sinus. The lesion is measuring 53 into 28 into 30 mm, showing enhancement on post-contrast and causing mass effect as described above. It is likely a maxillary nerve schwannoma. My discussion: schwannoma, also called as Schwann's cell tumor or neurilemoma, is a benign tumor of the neuroectodermal origin arising from the Schwann cells of the neural sheath. It affects the peripheral nervous system, cranial nerves and spinal nerves, and even the autonomic nervous system. The etiology is anonymous, but it is said that the lesion arises by propagation of Schwann cells at one point within the perineurium. The schwannoma is generally a single lesion, but when it is allied with neurofibromatosis, it can be multiple too. This tumor can occur at any age, with prevalence in females more than males at a ratio of 2:1. The clinical features of schwannoma of paranasal air sinuses depending upon the site and affected nerve and compression of the surrounding neural structures. Other clinical symptoms such as swelling, numbness, nasal obstruction, exophthalmos, mucopurulent rhinorrhea, hyposmia, anosmia can also be observed. There is no classical radiological sign of this tumor. It is generally presented as a unilocular radiolucency with well-defined sclerotic border on routine extraoral radiographs. On CT scan, the characteristic lesion is a well-defined mass associated with healing of the surrounding bone by the tumor. CT scan is useful in evaluating the size, location, and erosion of the bony surfaces. The differential diagnosis of the schwannoma are polyp. Schwannoma of the paranasal air sinuses are polyp, ossifying fibroma, ameloblastoma, dentigerous cyst, solitary bone cyst, spindle cell carcinoma, and other mesenchymal tumors. The likelihood of malignant alteration of the schwannoma is unusual. And treatment: under general anesthesia, with the help of endoscope,
We did the initial septotomy and later left medial maxillectomy using modified Denker's approach. And later the tumor was exposed and removed with the help of debrider. After removal of the tumor, the clipping of the internal maxillary artery was done, and the defect was packed with Surgicel, and later Merocil and Soframycin nasal packing was done. The hemostasis was secure. Surgery ended without any complications. Post-operative recovery was uneventful. On the second post-operative day, nasal packing was removed and the patient was discharged from the hospital. On histopathological examination, it showed encapsulated well-circumscribed lesion having a zonal pattern.
Doctor, time up,
composed of-
doctor.
Okay, sir.
Sir, any questions?
Okay. Thank you, Dr. Sriharsha. Our group candidates is over, no, sir?
Yes, sir. Maybe from 19th, new judges are going to join, sir. New judges are going to join.
Okay.
Thank you, sir. Thank you for your.
Okay, sir. Thank you.
For your sir. From 19th, we'll inform you when the judges are online. So stay on. Next candidate, stay till you are being called. Okay.
Sir, shall we leave?
Sir, we'll confirm with the Dr. Ramesh sir, organizing secretary. We'll just. So. Sir, I think Dr. Ravi sir also just now added, sir.
Good afternoon, sir. We welcome Dr. D. Ravi sir from Mandya Institute. Excuse me, 1 minute. Sir. Yeah. Dinesh.
Sir, Rajendra sir, Dr. Anish sir, next judges have joined the session, sir. So I think you can leave, sir. Dinesh sir, your voice is not audible. Dinesh sir, your voice is not audible, sir.
Okay, am I audible now?
Yes, sir. Yes, sir. Now you are audible, sir.
I'll log off now. Okay.
Yes, sir. Yes, sir. Thank you for joining the session, sir.
Good afternoon, sir. We welcome Dr. D. Ravi sir from Mandya Institute of Medical Sciences and Dr. Sri Krishna sir from AIMS BB Nagar, sir. Judges for the current session. Sir, with your permission, can we start the session, sir?
Yes, sir.
Okay. Sir. The next candidate is Soumya Niharika, presenting a rare case of an adult subglottic cyst leading to airway obstruction. Soumya, are you online? Can you share your screen?
Yes, sir. Yes, sir. I'm trying to share
When
my
you're ready,
screen,
just
sir.
tell. I'll start the timer.
Okay, sir. Sir, is my PPT visible, sir?
No.
Sorry, sir. Just a second.
Yeah, can
Is
you,
it-
yeah, start.
Can I start, sir?
Yeah.
Good afternoon, everyone. I'm Dr. Soumya Niharika Basi. Today, I'm going to share a rare case of an adult subglottic cyst leading to airway obstruction. Introduction. Subglottic cysts are rare benign tumors commonly occurring in neonates and premature infants. However, their incidence is extremely rare in adults. In premature infants, the cysts are usually multiple and arise in the posterolateral aspect of the subglottis. Most cases are acquired secondary to endotracheal intubation. Typically, it presents months or years after extubation as intermittent stridor, which varies with posture and potentially causing complete airway obstruction. This is a case report of a 56-year-old male presented to our outpatient department with a complaints of difficulty in breathing since 2 months, which is gradual in onset and slowly progressive and aggravated in supine position. This patient also had noisy breathing since 1 month, which is hoarse in nature, continuous throughout the day, with no positional or diurnal variation. This patient had a history of endotracheal intubation 18 years ago for cholecystectomy. Patient has no known comorbidities and no history of addictions. This is the video laryngoscopic examination of the patient. Here we can see a single round pale pinkish mass in the right subglottic region, which is sessile and does not move with respiration. It obstructs most of the posterior part of the airway. As for this patient, no other radiological tests were done as the lesion appeared to be single and localized. Tracheostomy was done in this patient prior to secure the airway, and then we proceeded for excision biopsy. This is the intro video of the patient. Here, Lindholm's vocal cord separator is placed to expose the subglottic lesion. And using the microlaryngeal scissors, the cystic wall is incised. With the help of microlaryngeal cupped forceps, it was held in place. As the lesion was huge, it was resected in a piecemeal manner. Initially, this part is removed, and a subglottic remnant is observed, and it was also resected from the adjacent mucosa with the help of microlaryngeal scissors until there was no remnant left. Postoperatively, patient showed no significant improvement in the symptoms and had no recurrences in the post-op visits. Grossly, the specimen is nodulocystic, and microscopically, the cyst wall showed stratified squamous epithelium and shows inflammatory cells, infiltration by lymphomononuclear cells of few neutrophils, edematous connective tissue with the areas of hemorrhage and fibrin deposition, which are all features suggestive of ductal cyst with chronic inflammation. These are my differential diagnosis, sir. Laryngeal papilloma, sarcoidosis, Wegener's granulomatosis, intubation granuloma, chondroma, hemangioma, tuberculous granuloma. Discussion. Injury during intubation and posterior subepithelial fibrosis in laryngeal mucosa leads to ductal dilatation and cyst formation due to improper evacuation of the submucosal glands. This pathophysiological mechanism could explain the time lag typically seen between intubation and the onset of the symptoms. The location of these lesions is consistent with their iatrogenic origin, given that they occur in the subglottic region. Several studies have demonstrated a sequence of acute ulceration, mucosal necrosis, granulation tissue production, and healing with epithelial regrowth, subepithelial fibrosis, and squamous metaplasia. Acquired subglottic cysts are a rare cause of airway obstruction, and these should be included in the differential diagnosis of the patients with intubational history. Timely surgical removal seems to be an effective treatment to prevent airway obstruction and fatal outcomes. Surgical resection has a low recurrence rate and fewer complications. Thank you, sir. These are my references.
Sir, any questions, sir?
Nothing from my side, sir.
So can we go to next candidate, sir? Dr. Monica, can you share your screen? Tell me when you're ready. Should I start? Dr. Monica, your voice is not audible.
Sir, I'm ready, sir.
Yeah, you are. Okay, I'm starting. Start.
Good afternoon, everyone. Good afternoon, everyone. I'm going to present a case of congenital cholesteatoma in adolescents. Myself, Dr. Monica. Introduction. Congenital cholesteatoma comprises squamous epithelium retained in media space. During immunological migration of squamous cells, there is no connection to tympanic membrane, which is normal in appearance and intact. The criteria for diagnosis congenital cholesteatoma include intact tympanic membrane, no history of prior ear infection, no history of prior ear surgery, including tympanostomy tubes. Congenital cholesteatoma most commonly occur in anterior superior quadrant of middle space, reflecting the pathway of embryological cell migration. A case report: a 19-year-old male presented to our OPD complaining of left ear pain and mild hearing loss since 3 years. There is no history of ear discharge, trauma, tinnitus, vertigo, oral fullness, and autophony. There is no history of nose and throat complaints. Past history and family history are insignificant. General examinations and vitals are normal. Coming to local examination, in photoendoscopic examination, right ears appear pearly gray in color with cone of light present in anterior inferior quadrant. On cingulation, it is mobile. In left ear, you can see grayish white bulge involving posterior quadrant, partly extending into anterior inferior quadrant. On cingulation, there is decreased mobility. Preoperative audiometric findings include right ear 18 decibels hearing level and in left ear 37 decibels hearing level. Impedance: right ear A-type tympanogram with absent reflexes indicative of no middle ear pathology. B-type indicative of middle ear pathology. Coming to tuning fork test, Rinne's test: in right ear it is positive and in left ear it is negative. Weber's test: it is lateralized to the left ear. Temporal bone: you can see here the soft tissues present in left middle ear cavity and opacification is noted in left mastoid ear cells. Coming to surgical management, we have performed left cortical mastoidectomy. Post-auricular incision is given and temporally spatial graft is harvested. Pinna is retracted and you can see the intact tympanic membrane, where behind the intact tympanic membrane we can see the whitish bulge. Now the canal incision is given at 6 o'clock position and another incision is given at 12 o'clock position. Now we are elevating the tympanomeatal flap. The whitish mass is seen behind. After reflecting the tympanomeatal flap, we have entered the middle ear. The whitish mass is seen in the middle ear, which is sent for histopathology. Spine of Henle is identified and McEwen's triangle is marked. Spine of Henle is identified and McEwen's triangle is marked, and drilling is continued till we reach the antrum. But you can see the artetus is blocked here due to granulation tissue. Upon removal of granulation tissue, the patency is achieved. On clear inspection, there is erosion of long process of incus and suprastructure of stapes, and reconstruction was done with boomerang cartilage, which is taken from the tracheal cartilage. This is the histopathology report of the cholesteatoma. This is keratinized squamous epithelium filled with laminated keratin tissue debris. This is keratin debris. The stroma is seen with inflammatory cell infiltration and fibrocollagenous connective tissue. Post-operative findings of the patient after 4 weeks. Post-operative audiometric findings are left ear, it is improved to 28 decibels hearing level. Discussion: congenital cholesteatoma diagnosed asymptomatically by a chance visit to a clinic. The diagnosis of congenital cholesteatoma is usually made by clinically and otoscopic examination. CT scan of the temporal bone is performed to assess its extension. Treatment remains surgical. The main objective is to eradicate the disease to restore a healthy ear. The second objective is to restore or improve the ossicular shape. The prognosis depends on its location, age of the patient, degree of ossicular involvement, and number of involved sites.
Conclusion: conductive hearing loss was the most prevalent presenting symptom of congenital cholesteatoma due to intact tympanic membrane and lack of association with infection. Diagnosing congenital cholesteatoma is challenging and delayed. Early diagnosis of congenital cholesteatoma is crucial to avoid extensive damage to medullary structure, to achieve better hearing outcome, and to reduce the risk of recurrence. These are my references. Thank you.
Sir, any questions for the candidate?
No, sir.
Can we next presenter, Dr. Deepika? Can you share your screen? Dr. Deepika, are you there? Dr. Deepika? So can we go with the next one? Sir, can we call the next presenter? I think Deepika is not there.
You can call the next presenter, sir.
Yes, sir. Dr. Santana Lakshmi, can you share your screen?
Yes, sir.
Yeah.
Good evening, Ravi sir and Sriharsha sir. Welcome, sir. Sorry to interrupt you.
Thank you, sir. Thank you, sir.
Sir, am I audible?
Yeah, start your presentation.
Good afternoon, sir. Today I'm going to do a case report on facial nerve schwannoma of the right intratemporal region. The facial nerve tumors are rare. The incidence is said to be less than 1% of all the temporal bone tumors, and the most common type is the schwannoma, which is arising from the Schwann cells. And the facial nerve schwannoma accounts only for 1 to 3% of cerebellopontine angle tumors, and it mimics vestibular schwannoma, and it should be differentiated from vestibular schwannoma. The presenting symptoms vary according to the site involved. Asymptomatic or atypical presentation often leads to misdiagnosis, and high degree of clinical suspicion and early imaging can lead to diagnosis. History: a 50-year-old man presented to ENT OPD with complaints of facial asymmetry, deviation of angle of mouth to the left, and incomplete closure of right eye for past 1 year. And there were no history of ear discharge, earache, hearing loss, giddiness, or ringing sensation. No history of change in voice, difficulty swallowing, and no history of trauma to the ear. On clinical examination, bilateral external auditory canal and tympanic membrane were normal, and facial nerve examination grade 4 House-Brackman facial palsy was noted, and tuning fork tests were normal. On examination of the facial nerve, there was deviation of the angle of mouth to the left, weakness of the buccinator, and incomplete eye closure of on the right side, and nasolabial fold obliteration was observed. On investigation of HRCT temporal bone, on axial, both axial and coronal views, which identified a neoplastic lesion in the labyrinthine segment and perigeniculate region. On MRI brain, fusiform enhancing lesion arising from the 7th cranial nerve, probably a neurogenic tumor. So the surgical procedure planned was total tumor excision by intact canal wall mastectomy and facial nerve decompression. The surgical steps: the postauricular incision was given 5 mm behind the postauricular sulcus, followed by harvesting of the temporalis fascia and canthal cartilage, and standard or cortical mastectomy was done, followed by posterior tympanotomy, which was extended superiorly, and removal of malleus and incus was done for proper exposure of the tumor. And facial nerve decompression was done from tympanic to the mastoid segment. This is the grayish pink lesion showing the facial nerve schwannoma arising from the labyrinthine and geniculate region. This is the defect post removal, which was covered by the surgicel, flowcele, and temporalis fascia. And the facial nerve decompression site and the posterior tympanotomy site was covered by the temporalis fascia. And mastoid cavity was obliterated, and closure of the musculoperiosteal layer and skin closure was done. Postoperatively, on histopathology, the biopsy specimen confirmed the schwannoma of the right facial nerve, showing the antennae A pattern, that is hypercellular region, and antennae B pattern, hypocellular region, with Verroque bodies. This is the postoperative day 15 picture of the patient showing the grade 4 House-Brackman facial palsy. Discussion: the facial nerve schwannoma can arise anywhere from CP angle to the periphery of till the parotid region. In this case, the site of origin is labyrinthine segment and perigeniculate region, which is the most common site according to the literature.
The warning signs include facial palsy, middle ear mass, and hemifacial spasm. And diagnostic modalities should combine both CT and MRI. For advanced facial palsies, microsurgical excision should be done, followed by facial nerve repair. For early stages, stereotactic radiosurgery is an emerging option. So I would like to conclude by saying that any chronic facial palsy with no history of trauma or infection, we should suspect facial nerve tumors. And preservation of the facial nerve function is possible only if the patient presents in early stages. The management decision should be tailored to each patient based on the existing facial and audiovestibular function. And these are my references. Thank you, sir.
Sir, any questions, sir?
Nothing from my side, sir.
Thank
Dr.
you,
Dr. E. Likita Reddy, can you present your case? Dr. E. Likita Reddy. Dr. E. Likita Reddy, are you there? Sir, can we go with the next presenter, sir?
Yes, sir.
Dr. Deepak Peter, can you present your case?
Yes, sir.
Tell me when you're ready. I'll start the timer. Dr. Deepak? Yeah. Can you share your slides?
Can you? Is it audible?
Yeah, it is audible. I'm starting the timer. Can you start?
Okay. Good afternoon. I'm going to present a report on tumor in the shadows about understanding parapharyngeal space growths. Coming to the aim of the presentation, it is to present a case of left parapharyngeal space tumor in elderly age group to share my clinical experience involving imaging, preoperative preparations, approaches of excisions, and pathological findings. Coming to introduction, parapharyngeal space tumors account for about 0.5% of all head and neck masses. Most common were of salivary gland origin. 45% of all lesions were of salivary gland origin, and it usually arises in the pre-styloid compartment. It usually composes of pleomorphic adenomas and also carcinomas such as adenocystic carcinomas and mucoepidermoid carcinomas. Coming to neurogenic lesions, neurogenic lesions also accounted for 41% of lesions in the parapharyngeal space. It is constituted by paragangliomas, schwannomas, and neurofibromas. And majority of malignant neurogenic lesions usually arise in the post-styloid space. Coming to my case details, it was a 60-year-old man presented with progressive dysphagia and ovoid swelling of size 3 into 2 centimeters, firm in consistency, noted in left submandibular region. An intraoral bulge was visualized, completely obscuring the uvula. There was no history of dyspnea, trismus. There was no history of any hypertension, flushing, or any history of any cranial nerve palsies. Coming to examination, a smooth intraoral bulge was noted, causing medial displacement of left oropharyngeal wall, obscuring soft palate and uvula and posterior pharyngeal wall. Direct laryngoscopic examination showed normal vocal cord mobility. And coming to imaging, which was done, a contrast CT neck was done, which showed a large focal mass in the left parapharyngeal space, which was well circumscribed with a thin capsule, and carotid vessels displaced posterolaterally, indicating a pre-styloid lesion. An MR angiogram was done, which showed solid cystic components with feeders of left external carotid artery to the soft tissue component. Coming to preoperative embolization, which was done as a precursor to the surgery, electrotracheostomy was also done for securing the airway, following which a less selective left ECA arteriography was done, which showed tumor blush in left parapharyngeal space. Embolization of arterial feeders, namely internal maxillary artery, was done via a transfemoral axis, and post-procedure, an obliteration of flow in the tumor circulation was noted. Coming to the surgery, excision of the lesion was done in toto via an intraoral approach. Vertical incision was given over the intraoral bulge. Mucosal flaps were elevated, and tumor identification was done, followed by careful dissection. Ligation of the bleeders were done to secure hemostasis, and enucleation of tumor from the surrounding tissue was done, following which the incision was closed with sutures. Coming to postoperative care, patient had an uneventful recovery with no neurological deficits, and histopathology showed features suggestive of monomorphic adenoma with uniformly arranged baseloid cells with immunohistochemistry CK7 positive, P63 focal positive, and CD31 and CD34 negative. Coming to discussions, majority of parapharyngeal space lesions are usually salivary gland tumors, such as pleomorphic adenoma of the deep lobe of parotid, and also paragangliomas, schwannomas, and even metastasis from the nasopharyngeal cancers also form a majority of lesions. Here on the diagram, we can see a carotid body tumor, which displays the internal and external carotid artery, known as the Lyell sign, and also dissection of the carotid body tumor. Coming to surgical approaches, transcervical approaches can be carried out in combination with a transparotid approach based on the surgeon's opinion, with or without a mandibulotomy, for tumors that extend into the intratemporal fossa. Orbitozygomatic and transmandibular and transpalatal approaches have also been described. Coming to the diagram, here we can see a transcervical approach for resection of the pleomorphic adenoma of the parotid gland, which shows a modified Blair's incision, which shows the superior extension. And on the right side, we can see a novel surgical method, which is the transoral robotic surgery, which shows a complete excision of the left parapharyngeal space tumor with further closure of the space. Coming to why this topic, clinical significance, there's a potential of malignancy up to 20%. It can compress or invade the cranial nerves. It can have airway compromise and can lead to progressive dysphagia. It can also have diagnostic challenges where the early symptoms are vague or absent. And usually, the tumors arise in a complex or deep space. And accurate diagnostic imaging and surgical access are usually very necessary to plan surgery. And functional preservation of the nerves while planning surgery is needed. These are my references. Thank you.
Sir, any questions, sir?
Nothing from my side, sir.
Dr. K. Neetu Kiran, can you present your case?
Yes, sir.
Yep. Tell me when you're ready. Dr. Neetu? Dr. Neetu Kiran, are you ready? Hello? Dr. Neetu? Okay. Sir, can we go with the other presenter? I think there might be some technical problem at the presenter place.
Sure, sir.
Dr. Apeksha, are you there? Dr. Apeksha. Dr. Richa Prasad? Hello? Dr. Richa
Good
Prasad?
afternoon, sir.
Yeah, can you present your case?
Yes, sir.
Okay, present your case. Sir, serial number 27, sir. Dr. Richa Prasad will be presenting, sir.
Fine, sir.
Tell me when you're ready.
Yes, sir. Sir, can I, sir?
Yeah, start.
Is my presentation visible?
Yes, start. Full screen, please. Slide share.
One second.
Right lower corner. Near the zoom 174%, right lower corner.
Sir, one second. Sir, is it visible, sir?
No, make it to full screen.
Full screen number, right
Sir,
lower corner.
Maximize the slide.
Or slideshow. Beside
Click
animation.
on the slideshow.
Just help me on this.
Yes.
Okay. Now start your presentation.
Yes. Okay. Thank you. Good afternoon, everybody. I'm Dr. Richa Prasad. Today I'm here to present a rare case of lingual dermoid cyst. Regarding dermoid cysts, these are uncommon lesions in the head and neck region, constituting approximately 7% of all dermoid cysts presenting in this region. They're usually observed in lateral third of the eyebrow, followed by the floor of the mouth, and rarely on the tongue. They represent less than 0.01% of all oral cavity cysts, usually discovered at birth or first year of life, but can also clinically appear later in childhood. Case history. Presented to our OP, she complains of swelling over the tongue since 3 years. They informed mother, told the child was apparently asymptomatic 3 years ago. And then the mother incidentally noticed a single swelling over the dorsum of the tongue, which was initially the size of the peanut, which gradually increased to presence. She had no complaints regarding functionality of the tongue, mechanical obstructive features, or any features of hypo or hypothyroidism. On clinical examination, a single smooth vascular swelling of about 2 cm by 2 cm was seen over the midline of at the junction of posterior 2/3 and anterior 1/3 of the tongue. On palpation, it appeared firm to hard, non-mobile, non-tender swelling. Specific investigations included ultrasonography of neck, which showed both lobes of the thyroid in normal size, shape, and echogenicity. Thyroid scan was also done, which showed normal functioning of the thyroid gland, and there was no abnormal tracer concentration at the swelling at the base of the tongue. Computer tomography of this neck was done, plain and contrast. The features showed suggestive of dermoid cyst. Thyroid function tests were normal euthyroid. Surgical excision was planned under general anesthesia through a transoral approach. Coagulation-assisted excision of the entire dorsal lingual swelling was done. Sample was later sent for histopathological evaluation. This was the picture of the excised sample. The postoperative recovery was histopathological report showed lobules of seromucinous gland, dilated ducts and eosinophilic material, fibroadipose tissue, and skeletal muscle bundles. One focus even showed bits of cartilage. Now coming to discussion, epidermoid and dermoid cysts in the oral cavity are a rare finding, making up to less than 0.01% of all cysts in the oral cavity. Dermoid cysts are benign in the presence of adnexal structures such as sebaceous elements, sweat glands, and hair follicles within the lining. Theories of pathogenesis include entrapment of epithelial cell rest during the medial migration of lateral lingual swellings, and also traumatic implantation of the epithelium. Differential dorsal lingual tongue swellings can include the following. Clinically, dermoid cysts may be asymptomatic, often discovered as painless swellings growing slowly and gradually surrounded by normal mucosa. Cysts may enlarge to a point that the patient may present with difficulty in articulation, mastication, deglutition, and airway compromise. These are pictures I've procured from other articles showing the increase in size which actually cause mechanical and functional difficulties. Surgical plan is generally enucleation surgery is considered primary and most effective treatment method. Selection of surgical approach is critical and is based on the cyst size, anatomical location, and its relationship with geniohyoid and myelohyoid muscles. Now coming to the most important question, why this case? Rarity of this case, as previously mentioned, according to literature statistics, it is a very rare case. Diagnostic challenge associated with this, it can be mistaken for other conditions such as infections or tumors due to similar symptoms like swelling, dysphagia, or speech impairment. Potential for complications if not diagnosed and treated properly. Lingual dermoids can grow and cause functional problems, as mentioned previously. Anatomical considerations. Tongue is a vital organ with complex muscles and nerve networks. Removing a lingual dermoid can pose risks to speech, taste, and movement. This case presentation can discuss how to minimize risks during the surgery, and it could also be valuable for surgical training. Pediatric considerations, it's important because mostly we get children from pediatric age group. And contribution to literature, since it is generally because of the rarity, each case contributes to the literature and patient counseling. If we as physicians and surgeons are more aware of such cases, we can be at a better position to explain it to the patient regarding the surgery complications
Dr. Time,
and
sir.
etc. These are my references. Thank you.
Sir, any questions, sir?
Nothing from my side, sir.
Dr. Neetu Kiran, can you present your case?
I'm ready to present my.
Present.
Am I visible and audible?
Yeah, share your screen.
Yes, sir. Thank you. Is my presentation visible, sir?
Yes.
Sir, okay. I'm ready to start.
Start.
Good afternoon, everyone. Today I'm here to present a rare case of idiopathic bilateral abductor palsy in pediatric age group. I describe the case as uncovering the uncommon because it is extremely uncommon in pediatric age group, and it is important to uncover the idiopathic etiology. In the most common etiological features of bilateral abductor palsy are Arnold Chiari malformation with hydrocephalus and myelomeningocele, birth trauma, cardiovascular surgery, tracheoesophageal fistula repair. Though this bilateral abductor palsy is a common condition, it is extremely rare in pediatric age group and with idiopathic etiology. Coming to the present case, a 6-year-old female child was brought to OPD by her mother with complaints of noisy breathing since 6 months. Before 6 months, she was asymptomatic. Then she developed recurrent respiratory tract infections with history of fever, cough, cold, and respiratory distress, and she was admitted for 3 times and treated for the same. The mother noticed noisy breathing, which was insidious in onset, which was initially mild and present only during sleep and heavy exertion, but it progressed to respiratory distress even at rest. It was aggravated during episodes of respiratory infection. It was temporarily relieved during periods of remission. There was no history of hoarseness of voice, aspiration, and dysphagia. There was no significant past, personal, birth, and family history. Coming to examination, in the first visit, the child was conscious, coherent, cooperative, thin-built, and she was not on stridor. SpO2 was 100% on room air. Awake video laryngoscopy showed vocal cords in slightly adducted position. On the second visit, the child had history of respiratory distress on exertion. Awake video laryngoscopy showed intermediate position of the vocal cords. Later, the child presented directly with stridor with 88% SpO2 on room air with suprasternal retractions. I have a problem playing the videos. Coming to investigations, the direct laryngeal examination showed no structural abnormality of the larynx. The imaging was normal. Awake video laryngoscopy showed progressive reduction in glottic chink. The vocal cords were initially in slightly adducted position, later they were in intermediate position and then paramedian position. Serology showed no elevated immunoglobulins. Coming to the management, initially the patient was conservatively managed and was on regular follow-up. After the palsy progressed, emergency tracheostomy was done. Patient is now under surveillance for spontaneous recovery. Awake video laryngoscopy is being done once in every 3 months. Coming to the discussion of this case, every case of idiopathic bilateral abductor palsy should undergo imaging and serology to exclude all possible etiologies. The patient may present with biphasic stridor and aphonia, but the presentations of dysphagia, hoarseness of voice are uncommon. In progressive cases, the patient may compensate as the paralysis becomes denser. They may initially have big glottic chink and later they may tolerate small glottic chink. This is why they give a history which has occasional noisy inspiration or occasional limitation in physical activity. More than half of the patients require tracheostomy. Spontaneous recovery is seen in 60 to 70% of patients in 24 to 36 months. Minimum surveillance of 3 years is recommended before performing irreversible laryngeal framework surgeries. Reversible procedures are vocal cord suture lateralization. Irreversible procedures are lateralization thyroplasty, posterior cordectomy, partial arytenoidectomy, reinnervation procedures, posterior clicoid split, and spacer placement. Currently, laryngeal pacemaker is under trial. These are my references. Thank you.
Sir, any questions for the presenter, sir?
Nothing from my side, sir.
Dr. Atul Das. Thank you. Dr. Atul Das?
Hello, sir. Yes, sir. Am I audible, sir?
Yeah. Can you present it?
Is my screen visible, sir?
Yes. Present.
So, good morning, everyone. Today I'm presenting a case of fibrous dysplasia of maxilla. So, the aim of my presentation is to present a rare behavior and extensive bony tumor of maxilla in an adult male and the diagnosis and plan for management. So, fibrous dysplasia is a rare bone disorder characterized by abnormal growth of fibrous tissue in place of normal bone tissue. Fibrous dysplasia is often caused by genetic mutation in genus 1 gene on chromosome 20, which inhibition of GT-base activity, which is normally required to deactivate the G protein. So it results in an increased amount of cyclic AMP production in bone stromal cells, which leads to unregulated proliferation and differentiation, which in turn leads to overproduction of fibrous tissue in bones. So there are mainly 3 types, which are monostotic, polystotic, and facial, where 80% presents with swellings of facial bone. So 70 to 80% constotic, where maxilla is the most common site, followed by mandible. On histopathological examination, there will be masses of fibrous connective tissue with walls and strands of spindle cells, cellular areas, pocket of cartilage, and metaplastic bone formation, replacing bone marrow and eroding bone cortex. So coming into our case, the patient is a 26-year-old male who came to an OPD with a history of right-sided cheek swelling for 7 years, which was insidious in onset, slowly progressive, which was painless in nature with no aggravating or relieving factors. The patient also had a history of right-sided nasal obstruction with no other symptoms. The patient also had no significant illness or any history in the past. The patient is a non-alcoholic and a chronic smoker. So on examination, the patient was noted to have a single 8 into 7 centimeter size bony heart, non-tender irregular swelling over the right cheekbone, bounded medially by root of nose, laterally by 4 centimeter in front of pinna, superiorly infraorbital margin, inferiorly 5 centimeter above the base of mandible. Right infraorbital margin was noted to be a higher level than left side with obliteration of right nasal labial fold. There was also a smooth non-tender bulging of gingival buccal sulcus from second incisor tooth to the second premolar tooth on the right side. Blood administrations was normal for a total leukocyte count of 13,000 and a platelet count of 92,000. CT scan was done, which showed ground glass appearance of the maxillary sinus and maxilla bone with displacement of maxillary sinus and lateral wall, which is characteristic of fibrous dysplasia. DNA was also done, which showed a bulging of lateral wall of right nostril medially, which was obstructing the right nasal cavity completely. There was also a deviated nasal septum towards the left, and left nasal cavity was normal, and nasopharynx was normal as well. My differential diagnoses include simple bone cyst, non-ossifying fibroma, osteofibrous dysplasia, and adamantinoma. So the patient was managed with a right partial maxillectomy, where Weber-Ferguson incision was given to expose the entire anatomy of maxilla after raising tissue and periosteum. Intraoperatively, the patient was noted to have an extensive bony growth involving the anterolateral wall, posterior wall of right maxilla, ethmoidal, sphenoidal sinuses, and rotosygoma and heart palate. Anterior wall and floor of maxilla was removed with partial removal of posterior wall and medial wall by paring and drilling. Floor of orbit, rotosygoma, drilling was done and spared, and posterior part of posterior wall of maxilla was preserved. There was a heart palate defect present at the end of surgery. This was some of the intro photos where we can see the Weber-Ferguson incision. This was a tumor which was excised in toto and sent for histopathological examination. On HPE, it was noted to see fibroosseous lesion composed of numerous irregularly shaped trabeculae of immature woven bone seen in various shapes, which was in Chinese letter pattern. It also lacked the osteoblastic rimming and surrounded by fibrous tissue, which was numerous scattered congested blood vessels, which is again pathognomonic of fibrous dysplasia. These are some of the post-operatively. So coming into discussion, it's a rare non-cancerous bone disorder that primarily affects the facial bones, including the upper jaw or maxilla. It represents 2.5% of bone tumors and over 7% of benign tumors. It can occur at any age with no gender predilection. After puberty or bone maturation, its progression slows or ceases. The prognosis is generally good, and regular follow-up is essential. It may also require ongoing support, including dental care, pain management, and potential reconstructive surgeries. So to conclude my discussion, surgical planning for complete exposure of tumor is required. In some patients, complete excision of tumor of involved bone with reconstruction of resultant defect with autogenous bone may be possible. In some cases, FT debulking of regional fibrous dysplasia may be done. Recurrence of tumor is very rare, but lifelong continuous monitoring is required. These are my references. Thank you.
Thank you. Sir, any questions, sir, for the presenter?
Nothing from my side, sir.
Dr. Rahim, can you present your case?
Sir, am I audible, sir?
Yeah. Please present it, please.
Yes, sir. Is it visible, sir?
Yes.
Yes, sir. I'm starting, sir.
Okay.
Yeah. Good afternoon, sir. I'm going to present a case on hidradenitis suppurativa in bilateral post-auricular region. So hidradenitis suppurativa is a chronic skin condition characterized by painful inflamed nodules and abscesses, often leading to scarring and sinus tract formation. It is frequently misdiagnosed as boils. This results in delayed diagnosis, fragmented care, and progression into a chronic disabling condition with abscess formation that has a profoundly negative impact on quality of life. Today, I'm going to present a case of a 28-year-old male patient. 28-year-old male patient, an engineer by occupation, presented with complaints of swelling in both the post-auricular regions. Patient reported first episode in the left post-auricular region 4 years ago, followed by right ear 3 years back. Swelling was initially small, gradually increasing in size, and associated with fever and pain. It ruptured spontaneously with discharging purulent material. No aggravating factors, but relieved on taking medications. Past history is insignificant. Patient underwent incision and drainage 2 times in the last 3 years with no relevant medical history, no comorbids such as hypertension, diabetes, asthma, epilepsy. There's no history of trauma or surgeries in the past. Patient has been experiencing disturbed sleep due to aggravated pain, and there's no family history. General examination and systemic examination of the patient are totally normal. Local examination. Upon local examination, the left post-auricular swelling does not extend in the intra-auricular region, which is size extending 3 to 2 centimeters erythematous surface with multiple scars on the skin. Whereas on the right side, the swelling was from the post-auricular region till the angle of the mandible inferiorly, with a size of 5 to 3 centimeters with erythematous surface with multiple scars and grooves on the skin. The other local examination findings were normal. Bilateral palpable carotid arteries. On otoscopic findings were normal. Upon examination of the oropharynx, he had a poor oral hygiene with dental caries. Differential diagnosis: follicular pyoderma, chronic deep folliculitis, epidermal inclusion cyst, which typically has a central punctum, acne vulgaris, Crohn's disease, and of course, hidradenitis suppurativa. Investigations. All routine examinations were done. All of them were normal except CBC, which had a raised WBC count. CRP was elevated. Cultures of the sample was sent, which revealed Staphylococcus lugdensis. Histopathological examination was done, which showed follicular occlusion, follicular hyperkeratosis, infundibular follicular epithelial hyperplasia, keratin plugs, and perifolliculitis. Features likely suggestive of hidradenitis suppurativa of post-auricular region. Diagnosis. Based on the presentation, examination, and biopsy findings, the clinical diagnosis of hidradenitis suppurativa in the post-auricular region is considered. Treatment plan. We have started the treatment with medical management with oral antibiotics, analgesics, and antiseptics. After 1 week of antibiotics coverage, patient was taken up for wide excision with reconstruction using a posterior auricular artery perforator-based keystone flap under GA. These are the images which I have been sharing on the screen. And these images are done after incision and drainage. These are the post-operative photographs in which patient came for regular follow-up for 6 months, once in a month, and he had no recurrence. Discussion. Hidradenitis suppurativa is a chronic skin condition characterized by painful, inflamed nodules and abscess, often leading to scarring and sinus tract formation. The etiology is multifactorial: genetics, environmental factors, lifestyle factors such as excess sweating, wearing of tight clothes, cigarette smoking, hormonal influences, and obesity. Medical treatment includes topical antibiotics or antiseptics. For most severe cases, systemic antibiotics such as tetracyclines or hormonotherapy may be used. Steroid injections such as triamcinolone acetonide is injected into the sores, which might reduce the swelling and inflammation. Oral retinoids might be used as an option for some people with acne-like disease. Biologics to treat moderate to severe hidradenitis suppurativa, tumor necrosing factors inhibitors such as adalimumab and infliximab have been used in dampening the part of the immune system called tumor necrosing factor. If medical management fails, then we counsel the patient for surgery. Surgical techniques. Uncovering the tunnel, also known as unroofing. This procedure involves removing tissues to expose the tunnels. Punch debridement, also known as limit unroofing. Laser therapy. In case the treatment fails, we undergo incision and drainage or excision removal. Complications include acute infections, lymphatic obstructions, squamous cell carcinoma, arthropathy, bleeding.
Time's up, doctor.
Yes, sir.
Thank you. Sir, any questions for the presenter, sir?
Nothing from my side, sir.
Next presenter, Dr. K. Neeraj Kumar.
Thank you, sir.
Dr. K. Neeraj Kumar. Dr. K. Neeraj Kumar. Sir, can we go for the next presenter, sir? I think Neeraj Kumar is not available.
Yes, sir.
Dr. Diptaba Mishra.
Hello, sir.
Yeah, can you present your case?
Yes, sir.
Thank you.
Sir, am I audible and my...
Yes. Present.
Good afternoon, sirs. Today I would like to present a case of auricular mucormycosis with parotid gland abscess and facial nerve palsy. Introduction. Mucormycosis is an opportunistic, life-threatening fungal infection caused by fungi of the order Mucorales. It usually affects individuals with compromised immune systems like diabetes, hypertension, or past history of COVID infection or any other immunotherapy drug usage. Mucormycosis of external ear isolated is rare, and existing data is limited to several case reports. Same can be said for mucormycosis of parotid gland. Coming to history, a 13-year-old male patient presented to the hospital with chief complaints of right ear discharge for 3 months, deviation of angle of mouth to the left for 2 months, and right cheek swelling for 20 days. The discharge was thick and mucopurulent, yellowish in color, scanty in amount. It was foul smelling but not blood tinged. During the course of hospital stay, the patient developed fistulous tracts to skin, both in front and behind the ear, from which thick pus started draining. There was history of bilateral ear discharge since childhood. There is no significant history of suggestive of any immunocompromised status. This is the picture of the patient on the day of admission with the cheek swelling, and with his stay in hospital, he developed fistulous tracts. On clinical examination, general examination was normal. Otoscopy revealed mucopurulent discharge in right ear canal, filling up to the external auditory meatus. A 3 by 5 centimeter smooth diffuse swelling was observed over the right parotid region with excoriation of overlying skin. It was tender to touch with no fluctuation. Facial nerve function revealed lower motor neuron type, right facial nerve palsy, House-Brackman grade 4. Several investigations were performed. Ultrasonography of parotid and neck revealed a diffusely enlarged right parotid gland with multiple hypoechoic collections, with few of them showing internal echos and fistulous tracts to skin. Fine needle aspiration cytology suggested of granulomatous lymphadenitis or histiocytic disorders. A computer tomography of temporal bones was performed. It showed soft tissue opacification in middle ear. Ossicles were eroded with scutum, tegment tympani, tegment mastoidum, and facial nerve canal. A right parotid region showed an ill-defined soft tissue opacification with extension to, posteriorly to mastoid region. The patient was next taken up for otoendoscopy under general anesthesia. And right here, we saw mucopurulent discharge, slough, and unhealthy mucosa. Swabs were sent for culture sensitivity, acid-fast bacilli staining, and CBNAT. Histopathological tissue samples were also collected, and it showed numerous scattered broad accepted fungal hyphae with angled branching, and in necrotic areas, it was suggestive of invasive mucormycosis. The patient was started on IV antibiotics on admission. Injection of piperacillin tazobactam as well as injection metronidazole was given. However, the patient started worsening symptomatically and developed fistulous tracts to skin, both in front and behind the ear, from which was started draining. Daily sterile dressing was performed. Artificial teardrops were administered, and care was taken to prevent exposure keratopathy. These are the photos taken of the fistulous tracts during dressing. After histopathological confirmation, the patient was started on antifungal drugs. Injection amphotericin B lyophilized. 40 milligrams slow infusion was given for 14 days. The patient improved symptomatically with this treatment. Discharge from ear and fistulous tract was decreased, cheek swelling was decreased, and facial nerve function improved. However, after day 10 of treatment, the patient was switched to oral intraconazole due to elevated renal function tests. The patient was sent on follow-up. The patient was discharged while on oral itraconazole and advised to come for regular follow-up and dressing. Patient was also advised to use usage of artificial teardrops and eye patching at night and to perform facial nerve exercises. After 3 weeks, the discharge dried completely. Both fistulous tracts healed completely. Facial nerve function was restored partially to House-Brackman grade 3. In conclusion, absence of immunodeficiency or prior history of COVID is not sufficient to rule out mucormycosis. Also, fine needle aspiration cytology is not sufficient to rule out fungal etiology, and a histopathological examination is always required. A thorough clinical examination and high degree of suspicion should enable the clinician to diagnose and treat such cases early, leading to a good outcome. These are my references. Thank you.
Sir, any questions for the presenter, sir?
Nothing from my side, sir.
Thank you, Doctor. Next presenter, Dr. Akram Munisa Sufia.
Good afternoon, sir.
Yeah, you are not visible. Yeah, can you share? Tell me when you are ready. Okay, start.
Malignant transformation of a rare benign tumor. It's a post-op case of bilateral inverted papilloma presenting with recurrent papilloma and synchronous squamous cell carcinoma. Inverted papilloma is a rare benign tumor comprising 0.5 to 4% of the primary nasal tumors. Bilateral involvement occurs in only 5% of the tumors. Recurrence after surgery occurs in 28 to 74% of the cases.
and malignant transformation occurs in 5 to 15% of the cases. A 54-year-old patient presented to the ENT outpatient department with complaints of nasal obstruction on both sides since 4 years and blood-tinged nasal discharge since 1 year. No history of bouts of sneezing or repeated episodes of cold or watering of eyes and nose. No history of loss of smell, headache, or cheek pain. No history of weight loss, tooth loss, loss of sensation over face, or double vision. There's no history of trauma. Clinical examination. On anterior rhinoscopy, pale polypoidal masses arising from bilateral middle meatai, which was sensitive to touch, did not bleed on touch. The probe could be passed all around except laterally, and the septum was found to be pushed towards the right. Diagnostic nasal endoscopy was done to confirm the findings. Biopsy was taken from the said lesion and sent for histopathological examination, which revealed inverted Schneiderian papilloma with focal dysplasia on both the sides. Radiological examination was done. Computed tomography of paranasal sinuses showed opacification of all the sinuses and ostitic changes were seen. The patient was planned for endoscopic medial maxillectomy and endoscopic sinus surgery. Debridement of polypoidal masses was done on both the sides. Uncinectomy was done and all the sinuses were opened, that is the maxillary, the ethmoid, and the frontal sinus on both the sides. Later, inferior turbinectomy was done and the medial wall of the maxillary sinus was removed to expose the posterior wall of the maxilla. Bilateral anteronasal packing was done. The pack was removed on the second post-op day and the patient was discharged. The patient was lost to follow-up. He presented after 1.5 years to ENT department with complaints of epistaxis since 3 months. On anterior rhinoscopy, pinkish proliferative mass was seen in the right nasal cavity, sensitive to touch, not bleeding on touch. And the septum was deviated towards the right. Findings were confirmed by diagnostic nasal endoscopy, and a biopsy was taken from the said lesion and sent for histopathological examination, which was suggestive of squamous cell carcinoma in situ in nasal papilloma. Patient refused further investigations and treatment in spite of counseling. Inverted papilloma is a benign epithelial neoplasm arising mostly from the lateral wall of the nose. It usually presents with nasal obstruction, epistaxis, headache, and cheek pain. Confirmation is by biopsy, which shows tumor growing inward into the connective tissue. Surgery is the primary modality of treatment, and recurrence after surgery is common. And hence, follow-up is very essential. A 4-monthly follow-up for 2 years, 6-monthly follow-up for 4 years, and yearly follow-up for 10 years is important. The rate of malignant transformation is 5 to 15%. So, biopsy and histopathological examination is necessary before the surgery. Thank you.
Sir, any questions, sir?
Nothing from my side, sir.
Thank you. Next, Dr. Meghana. Dr. Meghana?
Yes, sir, I'm here, sir.
Yeah, can you present your case?
Yes, sir.
Yeah. Can you share your screen?
Yes, sir. Am I audible, sir?
Yes, slideshow, please.
Yes, sir. Good morning. I'm Dr. Meghana, and my aim today is to present a rare case of entomophthalmomycosis due to conidiobolus in an adult female. So, what is entomophthalmomycosis?
It is a chronic inflammatory granulomatous disease involving the rhinofacial subcutaneous tissues and paranasal sinuses. It leads to formation of firm subcutaneous nodules in the rhinofacial region. About 200 documented cases of the disease have been described, and the majority are from the tropics like Asia, Central America, and Africa. Patients present classically with painless, woody swellings of the rhinofacial region, which are often clinically misdiagnosed as soft tissue tumors. History of the present patient. She is a 45-year-old immunocompetent female who is agricultural laborer. She presented with mild left cheek swelling and headache, along with nasal obstruction, left side more than right, for 2.5 years duration, for which she underwent septoplasty along with functional endoscopic sinus surgery under general anesthesia 2 years ago, after which nasal obstruction and headache were relieved, but without significant improvement in the left cheek swelling. She now presented with an increase in the size and extent of the left cheek swelling and dull aching pain, along with new painless swellings in the rhinofacial regions. These swellings were predominantly in the left periorbital region and root of nose for 2 months duration. There was no history of any other constitutional symptoms. On clinical examination, there was a diffuse left-sided cheek swelling and which was non-tender, and the skin of the cheek appeared normal. A 2 into 2 centimeters well-defined fixed swelling was noted at the root of the nose, and a 2.5 into 3 centimeter well-defined fixed swelling was noted in the left superior periorbital region. Both the swellings were woody hard in consistency, non-tender, with no local rise of temperature, or the skin over the swellings is thickened but was pinchable, suggesting that the lesion was in a deeper plane. Vision and extraocular movements appeared normal, and there were no palpable lymph nodes. Palpation of lymph nodes is important in this case to rule out soft tissue sarcomas and their spread to lymph nodes. Investigations. On HRCT nose and paranasal sinuses, there were erosions with bony remodeling of maxillary and the orbital walls, mucosal thickening of the maxillary, frontal, and sphenoidal sinuses, along with lesion in the left subbrow region, which was 20 to 22 millimeters with indentation of the globe and lid swelling along with edema. A polypoidal mucosa was noted in the maxillary sinus on left side on diagnostic nasal endoscopy. On histopathology, features suggestive of chronic granulomatous inflammation, which was probably of fungal in origin, was noted. And KOH mount showed positive for fungal elements, which on culture yielded Aspergillus flavus. On ultrasound-guided FNAC of the left periorbital swelling, there was an inflammatory lesion with broad, thin-walled, unbranched septate hyphae surrounded by glycoprotein antigen antibody complexes, which is classically known as the splendor-hopale material. And on periodic SHF staining, it enhanced the amorphous pink-colored splendor-hopale reaction. This is classical, but it is not pathognomonic of conidiobolus. It is also seen in other fungi and bacterial infections. Medical management. Cap itraconazole was given 200 mg twice daily after meals for a total duration of 5 months. Lesions have almost cleared up after 2 months, but was continued for 3 more months to avoid recurrence. Before and during the treatment, patient's liver functions, renal functions, and serum potassium was monitored, and patient was advised saline nasal douching. Patient showed dramatic improvement just with the oral antifungal therapy. Coming to discussion, it has been observed in tropical nations predominantly, and species of medical importance in entomophthalmos are Basidiobolus renarum and Conidiobolus coronatus. Basidiobolus infects buttocks, perineum, and thigh, whereas Conidiobolus attacks nose and paranasal sinuses. It is most common in agricultural field workers as they are present in soil, decaying fruit and vegetable matter. Infection is transmitted by inhalation of spores and by soiled hands, introduction into the nasal cavity. Disease involves a subcutaneous tissue, and the nodules in eyebrows, upper lip, cheeks give the patient a hippopotamus appearance. Untreated, that leads to progressive disfigurement of the face along with permanent disfigurement and disseminated infection and immunocompromised. Clinical diagnosis is by histopathology. Splendor-hopale phenomenon is seen, and rapidly growing colonies are seen on culture. Diagnostic challenges. These hyphae are difficult to find as they are outnumbered by commensals and become non-viable during biopsy procedure if not gently handled, and their growth is often suppressed by commensal fungi. For management, these are the other antifungals which can be used, and saturated solution of potassium iodide has a good chance application in management. So relapse is very common even after successful treatment. So this is the patient at onset of treatment, and this is 2 months after commencing treatment, and this is after 6 months. You can see a dramatic improvement. These are my references. Thank you, sir.
Sir, any questions, sir?
Nothing from my side, sir.
Dr. D. Rajkumar, can you present your case?
Yes, sir.
Yes.
Doctor, can you share your?
Yes, sir. Is my PPT visible, sir?
No. Yeah.
Good afternoon, sir. Going back to chronic otitis media with endolymphatic sac tumor. My aim is to present a rare case of chronic otitis media squamous type with endolymphatic sac tumor. Endolymphatic sac tumor is an uncommon, locally aggressive tumor which is located in the medial and posterior region of the petrous temporal bone and may involve the dura. It is a hypervascular tumor involving the endolymphatic sac with destructive changes. It involves the bone and may also show reactive new bone formation. These tumors may be sporadic or associated with von Hippel-Lindau disease. The diagnosis is based on clinical, radiological, and pathological correlation. The history of 23-year-old female came to the tertiary hospital with complaints of left ear pain for 2 months, which is insidious in onset, gradually progressive, throbbing type, no radiation, no aggravating and relieving factors. It was associated with hard of hearing in the left ear for 1 month, no history of any ear discharge or ringing sensation, no history of fever or giddiness, vomiting or angle of mouth deviation or double vision. No history of any complaints in the right ear, with no history of nose and throat complaints, no history of any comorbidities, no history of previous ENT surgeries. On clinical examination, patient was conscious, coherent, and cooperative. Vitals were stable. In the left ear, a smooth bulge was seen over the posterior wall of the external auditory canal, causing obstruction and obscuring the view of tympanic membrane posteriorly. In the right ear, the external auditory canal was normal and the tympanic membrane was intact. No nystagmus was elicited. Facial nerve function was normal on both sides. Cerebellar function tests were normal. On Rinne's test was negative on for 256 512 Hz and positive for 1024 Hz in the left ear. And in the right ear, it was positive for 256 512 and 1024 Hz. Weber's test was lateralized to left side. Schwabert's test was same as the examiner. And the nose and oral cavity were normal. And on otoendoscopy, in the left ear showed a smooth bulge over the posterior wall of external auditory canal, causing obstruction and obscuring the view of tympanic membrane posteriorly, and retraction was seen anteriorly, with grade 1 pars flaccida retraction. In the right ear, the tympanic membrane was intact. Puton audiometry showed normal hearing in the right ear and moderately severe mixed hearing loss in left ear. The CT temporal bones and MRI showed circumscribed lesion in the region of the left mastoid and heterogeneous enhancement which was noted lateral to the vestibule and lateral semicircular canal. The treatment, the patient was treated with left canal wall down mastoidectomy with vestibulotomy under general anesthesia. Cholesteatoma was seen eroding the posterior canal wall, floor of posterior cranial fossa, middle ear, vestibule, which was removed and sent for histopathological examination. Mass which was seen over the endolymphatic sac was also removed and sent for histopathological examination. Postoperative period was uneventful with intact facial nerve. Histopathological report was suggestive of cholesteatoma of mastoid antrum, and the other report showed endolymphatic sac papillary tumor, which was characterized by fibrocollagenous connective tissue with small cystic spaces lined by stratified squamous epithelium. Postoperatively, follow-up of the patient was done with otoendoscopy, in which neotympanum was intact on left side with a healthy mastoid cavity, and patient was symptomatically better with no complaints. The endolymphatic sac is located on the posterior-medial aspect of the temporal bone. Patients with endolymphatic sac tumors often present with gradual onset of sensorineural hearing loss and tinnitus, which may also show earache, vertigo, ataxia, facial paresis, and otorrhea. In this case, this endolymphatic sac papillary tumor was an incidental diagnosis confirmed by histopathological examination. Two histopathological categories of endolymphatic sac tumors were described, the follicular form and the papillary form. Immunohistochemical staining is useful in diagnosing these tumors, which stain positive for periodic acid shift, S100, cytokeratin, vimentin, and epithelial membrane antigen. The differential diagnosis would include jugulotympanic paraganglionoma, vascular tumors like hemangioma, meningioma, etc. So to conclude, endolymphatic sac tumor is a rare, slow-growing, but locally destructive temporal bone low-grade adenocarcinoma, and the likelihood of regional and distant metastasis is low. Wide excision with negative margins is the treatment of choice, and radiotherapy was done in patients with positive margins or incompletely resected gross disease or inoperable tumors. This case is presented here to aim at the better understanding and awareness of this extremely rare neoplasm. These are my references. Thank you, sir.
Sir, any questions for the presenter, sir?
Nothing from my side, sir.
Thank you, sir.
Thanks. Dr. S. Rachita, can you present your case?
Yes, sir. Sir, is my presentation visible, sir?
Yeah, yes, visible. Can you start?
Yes. Good evening, everyone. Today I'm going to present a case report on verruca vulgaris of vocal cord.
Continue, doctor.
Yes. My aim of presentation is to report a rare case of verruca vulgaris of the vocal cord, to describe its clinical presentation and management of the case, and lastly, to compare the results of case reports published in the review literature. Introduction. Verruca vulgaris is caused by human papilloma virus. It most commonly occurs on skin presenting as small elevated papules or nodules which are non-tender. It can also be seen on mucosal surfaces, but its occurrence in the larynx is rare. This becomes difficult to differentiate it from other laryngeal lesions. A total of 14 cases have been reported in review of literature, which are most commonly seen in men. This data has been taken from PubMed. Case history. A 48-year-old man came to the outpatient department with a change in voice for 20 days. There is no history of vocal abuse, no history of upper respiratory tract infections, no history of fever. There is history of tobacco smoking and intake of alcohol since 20 years. On indirect laryngoscopic examination, an irregular white growth is seen arising from the superior surface of anterior 2/3 of the right vocal cord with normal mobility. The growth seems to be immobile on phonation with adequate glottic chink. On general examination, there are no warty lesions noted elsewhere in the body. To confirm my findings of the indirect laryngoscopy, video laryngoscopy is done. An irregular whitish growth is seen arising from the superior surface of anterior 2/3 of the right vocal cord, not extending to the anterior commissure, and there is no contact lesion over the left vocal cord. There is an adequate glottic chink and the growth is immobile on phonation. This is the preoperative picture where we can see the whitish growth seen over the superior surface of the anterior 2/3 of the right vocal cord. Hence, to arrive at the diagnosis, the patient was then planned for direct laryngoscopy guided biopsy under general anesthesia. Biopsy was taken and sent for histopathological examination. After 1 week, report came suggestive of verruca vulgaris of vocal cord. This is the histopathological finding. Papillomatous epithelial proliferation with prominent hyperkeratosis, hypergranulosis, orthokeratosis, parakeratosis, and coilocytic changes were seen. There are elongated reti ridges showing angulation towards the center. Then the patient was planned for total excision of the lesion. Microdebrider assisted excision of the lesion was done. The patient was followed up post-operatively after 1 week. Thereafter, every 15 days till 3 months to look for any recurrence. This is the post-operative picture where we can see there is no residual growth over the superior surface of the right vocal cord. Discussion. Fechner et al. Misdiagnosed 2 male patients with superficial keratotic lesions as verrucous carcinoma and squamous papilloma, and they were treated with hemilaryngectomy and local excision respectively. The histopathological features of both these lesions are similar to Verruca vulgaris, hence easily misdiagnosed. There are distinct histopathological features which we have been seen earlier to Verruca vulgaris, which are not to be overseen to avoid misdiagnosis. Murad Topdak et al. Reported 3 patients with Verruca vulgaris, and the incidence is most commonly seen in men. Barnes et al. Diagnosed a patient of Verruca vulgaris with positive for human papilloma virus type 6 in a female patient. Sajid et al. Diagnosed a patient with Verruca vulgaris based on histopathological findings, despite failure in demonstrating HPV, and removed the lesion using a cold-bladed surgical intervention. The disease also isn't known to have recurrences. However, post-operative follow-up should be done to note any residual disease or for recurrence. The longest follow-up was done for 17 years long. Still, no recurrence has been noted. Conclusion. In verrucous lesions of the larynx, Verruca vulgaris should be considered as a differential diagnosis, though it has been rarely reported in the literature. As it is a rare disease, it is easily misdiagnosed as other laryngeal lesions. Histopathological examination remains the mainstay in diagnosis and management of the lesion. Once it is confirmed by histopathological report, after excision of the lesion, the patient should be followed post-operatively for recurrence. These are my references. Thank you.
Thank you, Doctor. Sir, any questions for the presenter, sir?
Nothing from my side, sir.
Dr. K. Madhu Chakravarti, can you present your case?
Yes, sir. Good afternoon, sir.
Present your case.
Yes. Good afternoon, sir. Today, my aim is to present a rare case of chondroid syringoma of root of nose. Chondroid syringoma is an unusual benign skin appendageal tumor originating from the eccrine and epigram sweat glands, resembling mixed tumors of salivary glands. It develops as a slow, enlarging small cutaneous nodule or mass. These lesions normally occur in older men on head and neck. History. A 65-year-old female patient presented to OP with chief complaints of swelling over the root of nose from 2 years. There was no history of trauma, no history of weight loss or loss of appetite, no history of nasal obstruction or bleeding from nose. There are no history of previous ENT surgeries and no history of any comorbidities. These are the preoperative pictures of the patient with a root of nose mass. On clinical examination, on inspection, a 3 × 3 cm smooth cystic swelling was present over the root of the nose. No sinuses or fistula are seen. On palpation, inspectory findings were confirmed, and 3 × 3 cm smooth cystic swelling over the root of nose present, which is mobile, non-tender, and there was no local rise of temperature. And on investigations, routine blood investigations are normal, and on routine computed tomography of paranasal sinuses, a lobulated soft tissue lesion with peripheral calcifications measuring 2.7 anterior-posteriorly is seen. And on fine needle aspiration cytology, cytosmear shows good cellularity consisting of tumor cells arranged as single scattered cells in the background of myxoid nature. Impression was atypical cartilaginous tumor, grade 1 myxoid chondrosarcoma. These are the intraoperative pictures. The excision was a treatment of choice. The infiltration was given and the incision was given superiorly and the flap is raised inferiorly. And the dissection was tumor was done in toto and mass was sent for histopathological examination. And on histopathological report suggests a benign head neck cell tumor chondroid syringoma. This is a post-operative pic of the patient. And then on discussion, chondroid syringoma usually presents as swelling in the areas of head and neck, most commonly the nose. These are morphologically identical to pleomorphic adenomas, benign mixed tumors of salivary glands, and these are less than 0.1% of all cutaneous tumors. Pathophysiology, benign head neck cell proliferation with wide range of differentiation and metaplastic changes in its epithelial, myoepithelial, and stromal components. There are no clear etiological factors. Treatment is surgical excision, recurrence is rare, and electroresection and CO2 laser have also been used. Conclusions, chondroid syringoma is a rare head neck cell tumor resembling pleomorphic adenoma involving males and more than females over age of 60 years. Chondroid syringoma should also be considered as a differential diagnosis for smooth cystic swelling over head and neck. These are my references, sir. Thank you.
Thank you, Doctor. Sir, any questions for the presenter, sir?
Nothing from my side, sir.
Sir, all the presentations are over, sir. We have 4 absentees. Dr. Deepika Vantaram, Dr. E. Likita Reddy, 26 number Dr. Apeksha Nivare and Dr. K. Neeraj Kumar. If anyone are there, kindly respond for the presentation. Sir, Ramesh sir, can you?
Thank you, Sagar.
Thank you, sir. Thank you, sir.
Yeah. Once again, check with the phone numbers.
Okay, sir. I'll check with the phone number, sir.
Thank you, all the judges, for your precious time, sir. Dr. Ravi, sir, from Mandya. How are you, sir? Yeah. Yeah. Dr. Srikrishna, sir, from AIMS BB Nagar.
Thank you, sir.
Thank you so much, sir, for your valuable time. Yeah. This session was almost ended, sir. We will confirm within 2 minutes. Any candidates want to present, we will take, sir. Otherwise, within 2 minutes, we will finish up this, sir. Yeah, it's confirmed. No candidate is available to take for presentations. Thank you so much, judges. Once again, thank you, coordinators and the postgraduates who have presented very well. This presentation is more important rather than a winning. Yeah, all are the winners. Okay. We will give certificates for all the participants. The only best 10 will they have to present at the conference venue. Thank you so much, sir. We are concluding this session, sir.
Thank you, sir.
Thank you. Thank you, sir.
Thank you, sir. Bye, sir.
Bye.
Thank you.
Yeah, Sagar. Thank you.
Sir,
Bye.
thank you, sir. Thanks.
Sagar
Bye,
and
sir.
Ram.